We'll start in about 15 seconds. Okay, well, greetings to the world. My name is Tanuj Nakra. I'm a facial cosmetic surgeon in Austin, Texas, and I'm very pleased to welcome you all to the first Hair Talks by Global Cosmetic Surgery. My career has had quite a wonderful ride, and a large pillar of my own professional existence is academic education. Having been steeped in the UCLA tradition with Bob Goldberg, it is a major part of who I am. And when we went into the pandemic, we all felt that loss of connection from the meetings that we missed while having to stay at home and quarantine. But there's an old Indian tradition that from darkness comes light. And in the depths of the pandemic, we were able to find light, and these virtual platforms allowed us to find each other again online and to engage in the scholarly activity of academic education, which is so important to all of us. Global Cosmetic Surgery was formed by myself and Dr. Deborah Shom, and we've put on numerous meetings now with thousands of participants from around the world. We've had the pleasure of introducing luminaries and educators from around the world who've given us unbelievable amounts of education and knowledge. And I'd like to introduce Deborah Shom as my co-director. Deborah comes from Mumbai, which is arguably the center of the world for Indian cosmetic surgery. And he's the first surgeon to be certified by the American Board of Facial Cosmetic Surgery. And so together, we see eye to eye in so many areas, and it's been our pleasure to host these global cosmetic surgery meetings. And so I'd like to hand it over now to Dr. Deborah Shom.
Thank you, Tanuj. Thank you once again for together formulating what is the fifth meeting from Global Cosmetic Surgery. Each of our meetings up until date have had approximately 3,000 registrations. Today's meeting is no different. It's a very niche meeting, and for such a niche topic to have 1,200 plus registrations from about 25 plus countries is amazing. It just shows us that we are about to put together another stellar show. And obviously, the job of Global Cosmetic Surgery is to make education available for all. Today, using technology, each of us can sit in different parts of the world. There are faculty who've joined in from Florida, from Hawaii, from India, and from other parts of the world. And we are able to together congregate and celebrate, in some ways, the pandemic. So there's a silver lining to every cloud, as Tanuj said. And using tech, we've been able to take education to the next level. My job is to thank everyone right at the beginning of the meeting. So I wanted to thank QR678, which is one of the sponsors and which has made an educational grant available for this particular meeting. Wanted to thank all our wonderful faculty who've joined in from different parts of the world, including London and so many other countries, Kuwait and so many other countries. Thank all the delegates, 1,200 plus of them, and maybe a few more joining in from 25 plus countries who've joined in for this niche meeting from all over the world at different time zones. It's amazing, and you all really give us the succor to try and make sure that we take education forwards. I wanted to take this opportunity to thank the main coordinator of the meeting, Dr. Arunda Abrol, who's also our current fellow in cosmetic dermatology, and Dr. Monica Surana, who's our current fellow in facial plastic and facial cosmetic surgery, and other members of the GCS team, without whom this would not have been possible. Wanted to thank the opportunity to, wanted to thank Swarnim Touch for being the tech partners as usual, and RioCon for being the marketing and the branding partner for this particular meeting. Now, moving on to the academic congregation, it's my pleasure to introduce the chairpersons who themselves need no introduction in this particular meeting. Dr. Michael Gold is joining in from Hawaii, and he's been a big supporter of the global cosmetic surgery movement. And really, I mean, what can you say about a gentleman who's published over 500 published papers, 40 textbook chapters, and is a world-renowned name in every place of the planet that he goes to. And the most important thing about Michael is seeing him in person. You would never, ever imagine that he's quite the icon that he is. And thanks, Michael, for being so humble and for taking these meetings forwards. I also have the pleasure of introducing Dr. Rachita Dhurat. And Dr. Rachita Dhurat, when we were thinking of putting this meeting together, we wanted someone from India who was actually an equivalent of Dr. Michael Gold in taking hair forwards. And Dr. Dhurat has been one such iconic personality. She's been the professor and the head of the Department of Dermatology at one of India's largest medical colleges. And there are generations of dermatologists who owe their training to Dr. Dhurat. And she really is everything that hair really symbolizes from an Indian perspective. So thank you, Dr. Dhurat, for being one of the chairs of the meeting as well. Our third chair for the meeting is Dr. Dan McGrath. And Dr. Dan McGrath has been the past president of the American Board of Hair Restoration Surgery. And Dan used to be a general surgeon who's now moved into cosmetic surgery and does hair transplant surgery, and is one of less than 200 hair replacement surgeons to have achieved a level of expertise in hair restoration surgery, which is unparalleled. Thanks, Dan, for joining in at short notice, and thanks for taking the meeting forwards. Over to you, Michael. It's over to you and the chairpersons now. With this, we start off the first hair talks from Global Cosmetic Surgery, which will be a once in every 2-month meeting, which will now be taking hair and all its science forwards globally. Thank you, everyone.
My turn. Thank you. It's my pleasure to be here with and to share this with Dan and Rachita. It's an honor, really. And it's early in the morning, but we learn at all times. So that's fine with me, and I'm thrilled that you guys asked me to be part of this with the group that's here. Do we want to get right into the lectures?
Yes, what you could do is you could introduce the moderators as well, Dan.
Sure.
Michael, and then.
All right. So again, along with Dan and Rachita, it's my pleasure to introduce our moderators and our Tapan Patel. Tapan, great to see you. And Amit Luthra, it's also great to see you. And these are our moderators for the event for this. Our coordinators are going to be Dr. Gupta, Dr. Gosavi, and Dr. Abrol. So I just want everybody to know that. So I'll turn it over. Dan, do you have anything you want to say to start? Come off mute.
I certainly want to express my gratitude for being allowed to be part of this. Anyone who is involved in any level of passion when it comes to cosmetic surgery or hair restoration surgery can appreciate that this is no small effort. I have the honor of being able to introduce Dr. Amit Luthra. And please forgive me if I underscore this, but all of these surgeons and leaders have tremendous resumes. And if I leave something out, please forgive me. But obviously, he is a consultant dermatologist and laser and cutaneous surgeon. He is a leader, obviously a leader in his field. And we one of the best speakers. He even received an award at the MIPS in Korea and Thailand for his ability to get his message across. And this is what it's all about: is coming together as a group and unifying and being able to get messages across. I also have the honor of introducing Dr. Arunda Abrol, who until yesterday, we had not met. And I told her, aside from being a lovely, young, beautiful woman and extremely intelligent, but she, I understand, is a big part of what put this together, this whole program together. She's a life member and she's a resident member of the AACS, and obviously has her degrees in dermatology and venerology. She's a young and passionate dermatologist and cosmetologist. And we're just lucky to have this group on board. And so I would apologize if I've left anything out. I think the truth is we have a stellar board and a stellar group of individuals that will give a tremendous amount of information to people that they had not had the opportunity to receive had they not joined this meeting.
Hello, everyone.
And
Yeah, we
Rachita, come on
have
in.
coordinators for this meeting that is most awaited meeting of the day, head talks, Dr. Bhavesh Gupta and Dr. Monica Surana. Dr. Bhavesh Gupta is head transplant surgeon and oral and maxillofacial surgeon from Mumbai. He also operates in Sicily, Italy, and Sao Paulo, Brazil, to teach doctors from other countries. While Dr. Monica Surana is also maxillofacial surgeon from Gujarat, and she was a faculty of a global cosmetic surgery meet held in August 2021. And she was a gold medalist in her BDS curriculum. So over to the proceeding, Debraj.
I guess it's over to the moderators and over to the first talk then.
Thank you, Debraj. Hi, I'm Dr. Luthra from Delhi, and I'll be moderating along with my co-moderator, Dr. Tapan Patel, who's from London. And we are really honored to be here. Thank you, GCS, for inviting us. So straight away, we'll go on to the talks. We'll have a first talk from a speaker from Kuwait, Dr. Vivek Singhal. And he's done his undergrad and the postgrad from Delhi, but now he's based out of Kuwait. And the lecture that he's going to talk about is talking about the diagnostic approach to hair loss. And I believe that's pretty important, especially in the COVID times where you have so much of hair loss in COVID patients as well. So over to you, Dr. Vivek Singhal, diagnostic approach to hair loss.
Thank you, Dr. Amit, for introducing me. I hope my voice is clear. I'll share my screen now. All right. So directly coming to the topic of diagnostic approaches to the hair loss, this is quite a basic topic that I'm going to talk about, and it illustrates the importance of history taking and clinical examinations. We'll have great talks further. Just to highlight, 100 to 150 hair loss per day is physiological. We all know this. Now the scalp hair thinning becomes prominent after more than 50% of the hair loss has happened. So that's when we see the patient, and hair loss can be due to scarring or non-scarring alopecia. In the history taking, it's important to know whether it is focal or diffuse, and there are different causes for focal hair loss as well as diffuse hair loss. Focal hair loss can be due to alopecia areata, tinea capitis, or trichotillomania, while diffuse is often seen with telogen effluvium, anagen effluvium, or patterned hair loss or androgenetic alopecia. Systemic symptoms can be associated with the hair loss. So if we see that there is fatigue, weight loss with dry skin, we tend to think more in terms of hypothyroidism, and we need to treat the underlying cause. Telogen effluvium, as Dr. Amit mentioned, that this can be after a stress due to COVID or any severe infections, stresses, pregnancy, and the hair comes out in clumps. After using hair straighteners or strong shampoos, Trichoderexis nodosa should be thought of. Age of the patient is quite important. So if we see a child with hair loss, we tend to think of certain diagnoses. And if an adult woman is having a hair loss, we think of others. For example, in children, alopecia areata or tinea capitis will be more common as compared to fractional alopecia in a young adult woman. Prepubertal to young adults might have an onset early, but they will present in this age group with trichotillomania. Frontal fibrosing alopecia in postmenopausal women, we need to think of when we go for age history. In the family history, we need to think of patterned hair loss. If it is coming positive, then patterned hair loss has to be thought of. And in the congenital type of hair shaft disorders, we'll see more hair loss among the children. Now, associated local symptoms can be associated with like burning, pain, or redness, pustules, boggy swellings. These are mainly seen in scarring alopecias, while congenital shaft disorders can be associated with other anomalies like ichthyosis, teeth nail anomalies, as well as eczema in children. The past history can be important, so we need to take it carefully. And telogen effluvium can be triggered due to multiple causes. So we have to take a history of endocrine disorders if it is suggestive, autoimmune disorders, high-grade fever or severe sickness, as with COVID, surgeries under general anesthesia. Nowadays, there is a fashion of crash dieting and sudden weight loss. Now, we often see a hair loss after that, and which is triggered by telogen effluvium. Now, this weight loss can also exaggerate the patterned hair loss, which has happened after the dieting. Increase in weight in the last 6 months associated with acne, menstrual cycle changes, and increased facial hairs can be seen in polycystic ovary. Lupus can manifest with hair loss in 3 different ways, either as telogen effluvium or with lupus hair, which is a non-scarring alopecia, and DLE, which causes scarring alopecia. History of drugs is important in the recent past. So it's usually a diffuse and non-scarring alopecia when it happens with drugs. And there are multiple drugs which are implicated causing telogen effluvium, or they enhance the patterned hair loss. Now, anagen effluvium can also be triggered and it can cause the hair loss, which is often seen after antineoplastic agents or TNF-alpha blockers like etanercept or infliximab. Now, we need to remember that after the drug history, usually the hair loss happens 2 to 3 months after, but there is quite a variation among them. And the hair loss can start from days to years after the onset of a particular drug. Nutrition history has to be taken carefully, and it's usually associated with low calorie diet, low iron or low protein diet, and it occurs as a telogen effluvium. So it can happen after crash dieting, and it's also seen with anorexia nervosa or bulimia. Psychosocial history of diffuse hair loss is associated with anxiety and depression. Trichotillomania, as we all know, it can be associated with psychiatric illness. Now, stress association with alopecia areata has a lot of controversial results in various studies. In the family history, a positive history, as I mentioned, it can be seen in patterned hair loss with congenital hair shaft disorders, alopecia areata. Alopecia areata is may be associated with other autoimmune disorders. A history of hair care practices is important. So mechanical and tractional damage may happen due to prolonged ponytail hair styling, hair buns, and tight hair tying. Heat damage can happen after prolonged hair dryers, while chemical damage due to dyes, bleaches, and relaxers can happen. Menstrual history should be taken for regularity, pregnancy, menopause, oral contraceptives, and history of polycystic ovary has to be carefully assessed. Heavy menses can also cause telogen effluvium due to iron deficiency. Now, as a flow chart, we need to think of history, and 2 types of hair loss can happen due to hair shedding or hair thinning. Now, hair shedding can happen due to roots or due to broken hairs, and otherwise, hair thinning can happen in scarring alopecia, patterned hair loss, or inflammatory disorders. Coming to the examination, how should we examine? The examination of the hair should not only be confined to the scalp hair. We should also examine the face hair, eyebrow, eyelashes, and the body hairs. The position of the patient should be, he should be sitting, not lying down, and so that we can have a 360-degree examination. So when we are taking pictures, we need to see the front view, the back view, the top, and the 2 sides. And we should always remember that if a visible scalp is there, that means the person has already lost 50% hair density. Now, this is just to illustrate that the clips and the buns have to be opened when examining the hair, and just not the tip. So the hairs have to be parted from the front towards the vertex and back from the vertex to the front and same to the sides while examining the hair as well as the scalp disorders. Now, pattern and distribution of the hair loss is important. So a diffuse hair loss will suggest a diagnosis of telogen effluvium, while frontal and vertex might be seen in patterned hair loss. Marginal hair thinning will be seen in tractional alopecias. A receded frontal hairline might indicate patterned hair loss or frontal fibrosing alopecia. Now, we must remember that more than one pattern may coexist in a particular patient. So we have to assess the different patterns as well. Also look for the hair color, hair length, as I mentioned, other body hairs like eyebrow, eyelashes, and epidermal changes on the scalp skin. The epidermal changes can be in the form of either redness, scales, pigmentation changes, atrophy, or telangiectasia. As we all know, diffuse dryness and flaking suggest seborrheic dermatitis, while a well-demarcated red plaque with silvery scales will point towards a diagnosis of psoriasis. As we all know, the alopecia can be classified into scarring versus non-scarring. With a dermatoscope or a magnifying lens, we need to look for the follicular osteas, and scarring alopecias will be associated with loss of these follicular osteas or might be scar when we see it on biopsy. Just a glimpse of a few of the scarring alopecias. My collection of LPP, it has a gradual onset, it's usually seen in adults. Scalp itching, burning may be seen. Now we must remember that 50% of the cases might have LP at other sites. So it will be easier to diagnose in that case. Perifollicular erythema or scaling may be seen. Folliculitis decalvans is another cause of scarring alopecia, seen in young and middle age. It usually starts at the vertex and develops boggy inflammation with plaques and nodules. Follicular papules and pustules may be seen. Hair tufting can be present. Pseudopelade, we all know that it has a gradual onset, young and middle age. These are atrophic and hypopigmented patches, which are seen, and these are bare patches with irregular border. Other type of scarring alopecias can be central centrifugal secretory. It's supposed to be due to hair care practices seen in young adults. It starts at the crown and then extends centrifugally. Hair tufting is seen. DLE again is a cause for scarring alopecia. We often see it in young females. Scalp itching and burning is seen. Hyperpigmented follicular plugging with peripheral hyperpigmentation and telangiectasia is seen. Dissecting cellulitis is another cause. It's seen mostly in men. So it has a painful scalp. It may be associated with the follicular occlusion triad. Starts at the vertex as boggy plaques and nodules. Hair tufting is seen. So just a layout of how we should be examining. So we should go for full scalp examination, pattern and distribution, other body hair loss, and close-up examination to see whether it is a scarring or a non-scarring alopecia. Different type of tests which we do. This is the hair card test to see if any new hairs are growing. We use a white card in case of black hairs or black card in case of white hairs. Now we all know the hair pull test is there. So we use 4 to 5 different sites and we take like 50 to 60 hairs. As we all know, 10% of the hairs are in telogen. So more than 6 hairs will be positive in a particular site. And the hair tug test, which addresses or checks for the hair shaft fragility. So if the hair shaft is fragile, we'll find this test as positive. Thank you for your patient listening, and I hope you enjoyed the talk.
Thank you, Dr. Vivek, for a wonderful introduction to this. Just a quick question. We'll take the questions at the end, but just a quick question for you. In a clinical setting, if you have to recommend for the beginners, what kind of a diagnostic tool should they be using for diagnosing hair loss? Would you suggest something, or it just has to be plain clinical?
So first, it's the clinical. As we are taught from the medical sciences, we are always taught go for a detailed history taking and a clinical examination. And then we go to the investigative tools, which is the next talk. So of course, we will listen more about the investigative tools in the next talk. Clinical examination is paramount. That's what I will like, and hand over the mic so that the investigations are handled in a better way.
Okay, fair enough. So we'll move on to the next talk, and this is by Dr. Sonam Ramrakani. She's from Mumbai, and she's going to talk about the investigative procedures in trichology. Dr. Sonam, it's all yours.
Thank you, Dr. Amit sir, for the kind introduction. At the outset, I would like to thank GCS and Hair Talk for allowing me to share this. It will be my pleasure to be able to contribute in any further manner to understand and explain the trichoscopic investigations or the other investigative methods that we commonly use in trichology. I am now going to be sharing my screen. Is it visible?
Yes.
Yes. So I am going to be talking about investigative procedures in trichology. Like it was correctly mentioned, it generally has more than one causes. Understanding all of these causes becomes very, very important to be able to treat effectively. Moreover, investigations in trichology hold a very strong place in assessing the disease activity. While we may know the diagnosis, we do not really understand clinically if the condition is progressing, regressing, improving or not. It will help us track the patient through the clinical course. It also will help us generate evidence of results and collect data for research and optimization. Because of these reasons, I feel it is very crucial to understand how to investigate the hair correctly. The available methods in trichology could be invasive and non-invasive. The non-invasive ones, while partly were covered by the previous speaker, I would just go through them quickly. A daily hair count. For 7 days, the patient is asked to collect and count the hair shed in 24 hours. This is collected in a plastic bag and labeled with the date. If the average hair count stands to be more than 100, it is examined to rule out bulb and hair shaft disorders. While it can also help us assess, it can also help us track the improvement of the patient. But where does the magic number 100 come from? There is no evidence to suggest. I hope my screen is not moving. Am I correct?
You're on big.
So,
You're fine.
Yeah, so we do not have any evidence to know where the magic number 100 really comes from. In a study conducted, it was understood that the normal average hair loss is supposed to be 40 to 80 hair per day. Average woman complaining of hair loss would not lose anything more than 50 in a day. So 100 definitely needs to be revisited. Moving to the wash test, the patient is not going to wash the hair for 5 days and then wash the hair in a basin with a covered hole with a gauze piece. The hair collected in this test is going to be examined for the length, divided according to the length into less than 3 centimeters and more than 5 centimeters. Shorter hair and extensive hair loss would tell us it is chronic telogen effluvium. Longer hair and more than 200 hair would tell us it is acute telogen effluvium. Hair diameter diversity along with presence of miniaturization in the hair follicles would give us a clue about female pattern hair loss. Moving on to the next one. The 60-second hair count. It's again a very simple investigation that can be done. The patient is asked to comb the hair backwards from the back of the scalp forward onto a pillow cover or a contrasting sheet. Counting this hair for 3 consecutive times before a hair wash gives us an average hair fall. This is then repeated monthly and can be reported to the treating doctor. The hair weight analysis. A target area on the scalp is marked. The hair is clipped very close to the baseline. Hair is allowed to grow for a particular fixed period of time and clipped again and is subsequently weighed. This is more important for research-based evidence collection where we are trying to determine the efficacy of an intervention like a finasteride or a dutasteride or a PRP. A felt examination, like explained earlier, would help us observe the new finer hair growth at the frontal hairline margin. The tips of the hair would give us a clue whether it is new hair or it is a broken hair. The hair pull test, again, the patient doesn't wash the hair for 5 days, comes to the OPD, and we kind of hold between 50 to 100 hair between the thumb and the index finger. We then exert a gentle pull towards the hair tips. If there is more than 5 to 6 extractable hair, like explained earlier, it would indicate a positive hair pull test. This test would be important to assess if the hair loss is still active. The hair tug test, a similar pull would be exerted on the hair shaft. If positive, it would indicate hair fragility, which is more important for hair shaft disorders. While all of these tests seem very easy to perform and they are inexpensive, they help us to monitor progress, but none of them is diagnostic and neither is it standardized. Moving to the next subset, we have something called phototrichogram, wherein a small marked area is clipped. A photograph is taken under fixed light conditions. After 48 hours, the same area is going to be photographed again and the hair diameter is measured. Examining the two photographs, we can have an idea about the hair which is in anagen phase, the hair which is in telogen phase. We can get the exact percentage. We can get the rate of hair growth. We can also quantify the shed hair. So this helps us to understand the hair cycle in a better manner. Global photography. This is my personal favorite: quick, easy, reliable, reproducible, and an objective method of hair analysis. There are a few challenges to this though. For example, reflection of light and subsequent glare can completely spoil the result of a good photograph. For example, in the two images here, the top is a before and the lower image is an after. But because of the reflection of light, the scalp show in the lower image is actually more. This can completely ruin the result, and hence lighting in a photograph is the most crucial aspect. For conditions where we need to document results, we need to understand consistency with respect to patient position, light, and the camera settings are very, very important. What should be a good background? The best background would be a plain blue or a green non-reflective surface like a linen cloth. Removing hair accessories, like mentioned earlier, hair bands, hair clips, would help us to avoid diverting the focus, which is very, very important. A camera resolution of 1.3 megapixels sufficient for dermatological photography, which is not very difficult to achieve. Lighting being the most important part, we should always have a twin flash system, as this helps us balance the light and enhances both depth and texture, maximizing the visualization of the hair. For example, here again, the picture on the left with an excessive flash, you can't really make out the hair details, whereas the second image taken just a couple of minutes later with the proper lighting would be able to give you more insights into the hair. This is an example of a good photograph where you can document results like a before and an after 3 months of treatment. This is another such image. Moving on to the next one, trichoscopy. It simply means dermoscopic imaging of the scalp and the hair. While it is non-invasive, it's an in vivo technique where it has traditionally been used to examine suspicious skin lesions. It is nowadays becoming easy, handy, and more accessible to understand the scalp with a trichoscopic examination. It is reliable, it is reproducible, but yes, it does require expertise and can be time-consuming in the initial days. What do you require for a trichoscopy? A manual dermoscope with a 10x magnification should also be good, but if you have a video dermoscope with up to 1000x magnification would be great. Proper understanding is extremely crucial to pick up what is normal and what is not normal. Regular practice to keep looking at the normal scalp will help us identify the abnormal features when you're suspecting them. Basics. On a normal scalp, we'd be able to see thick terminal hair with 2 to 4 terminal hair present in each follicular unit. There would be very few vellus hair present. A homogeneous pigment system should be seen. Pinpoint white dots, which would represent the eccrine sweat glands on the scalp, are also considered normal. What are the uses of trichoscopy? It will help you diagnose certain conditions very easily. It will help you assess disease activity, avoid unnecessary biopsies, and if at all we are convinced we need one, it would help us have a better site for biopsy, which will give us more information. To diagnose conditions like pediculosis capitis, where you can't see the mite or where you can't see the lice or the nit, trichoscopy can come really handy. It can help you identify conditions like tinea capitis with its diagnostic features like corkscrew hair, zigzag hair, broken hair, and comma hair. Scalp psoriasis, where you can see the uniformly distributed red globules, which are indicative of the dilated capillaries on histology. It would almost stand confirmative of a scalp psoriasis. Shaft disorders, where you can see uniform beading at equidistant intervals and breakage at different levels from the scalp, would be diagnostic of monolithics. It would help you assess disease activity. For example, in this slide of alopecia areata, exclamation hair is seen, black dot, empty hair follicles. These are all indicators of an active disease. Now, once you've treated the patient and the patient is coming back with a recovery, you'd be able to observe presence of more vellus hair, presence of more hair, the conversion of exclamation hair to more normal hair. This would be a very good positive factor to tell you that the patient is improving. Similarly, in pattern alopecia with its characteristic features, diagnosis is definitely one thing that comes handy. As the patient progresses, or if the condition is untreated, change of brown peripallar sign to white peripallar sign would be a characteristic feature. Presence of focal escherichia in a pencil eraser pattern would again be one of the typical findings in an advanced disease. While a patient on pattern alopecia who is under treatment and is responding favorably would come back with more thicker terminal hair growth and less vellus hair growth in the picture. It would also help us choose the best site for a trichoscopic guided scalp biopsy. While scarring alopecia can also be diagnosed clinically, sometimes it becomes difficult to choose which site to biopsy for. Lichen planopilaris, for example, in this case, the site was chosen where we could see tight concentric scales around the hair shaft.
2
This
minutes
would give
to
us
go.
we would have a very relevant finding on the histology where we would see lymphocytic infiltrate present around the follicles. Similarly, in other conditions, we have definitive features which we should look for before biopsy. Coming to the semi-invasive and the invasive methods, the semi-invasive being the hair mount, where the hair is simply plucked or clipped and examined under a microscope. This would be more relevant for shaft disorders and for infections of the hair, where you're looking for ectopics, endothics-like features. Similarly, moving on to a trichogram, no wash for 3 days, hair is plucked, examined, and would give us information on the hair growth cycle. The anagen-telogen ratio and the hair shaft cycle analysis would be better than using this test. The last, moving on to a scalp biopsy, it's a procedure where you remove a part of the tissue and send it to a lab for understanding the diagnosis. This should be deep and should include the entire follicular unit. It should include the subcutaneous fat and the depth of should be more than 4 mm. The direction is very crucial, should always be parallel to the hair follicle to avoid transectioning the hair follicle. Possibly 2 samples should always be collected for a horizontal sampling and a vertical sampling. The benefits of each being, in one of them, you can examine the dermoepidermal interface, while in the second, you can have more number of follicles to scan through. Choice of a lesion to biopsy should always be a fresh lesion. It should not be ulcerated or excoriated. If you're having an annular lesion, choose the edge or the margin of the lesion, but do not include the normal skin in the biopsy, as sectioning this can give you a non-specific. We all know what a normal biopsy would look like. There are certain specific uses of a biopsy, for example, picking up the disease really early. In this slide, central centrifugal
1 minute
scarring
to go.
alopecia. Yeah, I will be done. Central centrifugal scarring alopecia, we can identify premature deformation of the inner root sheath, which is characteristic to this condition in its early stages. Lichen planopilaris, a horizontal section can show you inflammation, which is intense at the level of the upper isthmus, but almost nil at the infundibular and the suprabulbar level. Moreover, specialized investigations like direct immunofluorescence can also be conducted from the biopsy sample, and hence it is extremely crucial. In conclusion, though most of the diagnosis can be done clinically, it is important to grade the disease, to evaluate it, and to keep a record of the progress. Global photographs combined with any quantitative hair growth method can complement the clinical data. And for office-based clinical practice, like Dr. Luthra was asking, a combination of global photography with trichoscopic examination and photography is the most recommended. This is also something that I practice in my clinic. That's it. Thank you.
Thank you, Dr. Sonam, for an absolutely wonderful lecture there. And we will probably take in some more questions for you at the end. And for the time, keeping up the time, so we'll probably move on to the next lecture. We have a young doctor from Delhi, Dr. Harsimran Kaur. She's a dermatologist, and she's going to talk about hair loss solutions, current medical and physical modalities, and hair treatment. Dr. Harsimran, it's all yours.
Good evening, everyone, and thank you, Dr. Luthra. I'm humbly honored to be sharing and speaking alongside such eminent speakers. I'll just share my screen. So hair loss can be emotionally devastating, and our aspirations are far from reality. Of all the various forms, today we'll be concentrating on the medical and physical management of the ones most frequently encountered, that is telogen effluvium, male and female pattern hair loss, and alopecia areata. Telogen effluvium is patients are generally anxious and need psychological support. One must remove any offending drugs and screen for underlying causes. Postpartum telogen is best treated with nutritional supplements, topical peptides, and correction of ferritin reserve to more than 70 microgram per dl. You may prescribe systemic dietary supplements either daily or sequentially. However, do note that studies suggest biotin and pantothenate work only in cases of a definitive deficiency. Oil is best avoided on the roots. Suggest chemical-free shampoos. Prescribe topical steroids only if trichodynia is a symptom. New on the block is a leave-on lotion consisting of caffeine, niacinamide, and pantothenol. Marine-derived proteoglycan replacement therapy has anagen-enhancing and catagen-delaying benefits, which is of profound importance in postpartum telogen effluvium. Widely used and very confusing are the newer peptides, of which the RCP protocol is gaining importance, that is Redensil, Capixil, and Procapil. So these are usually short-chain amino acids which have anti-inflammatory properties, and isoflavones like biotin and A inhibit 5-alpha reductase. Minoxidil can be prescribed for chronic telogen effluvium, and it works best in combination with the peptides. About 50% men by the age of 50 and 19% women in their lifetime suffer from pattern hair loss. We must reiterate to our patients that the management is effective but not curative. So after the initial 12 months of regrowth phase, they must continue therapies for longer durations. Only 2 drugs are approved by the US FDA for pattern hair loss, that is topical minoxidil and oral 1 milligram finasteride. So minoxidil is a pro-drug, and its active metabolite, that is minoxidil sulfate, is known for its vasodilatory, angiogenic, and cell proliferative activities. Prefer propylene glycol free foam forms over the lotions. Studies have proven that 5% forms are better than not just the 2%, but even more efficacious than the 10% solutions. In my personal opinion, rather than opting for higher percentages of minoxidil and saturating the receptors, it is better to target hair loss from different angles. So add topical peptides or finasteride. Adverse effects include allergic contact dermatitis, initial hair fall due to early telogen release. Oral minoxidil is suggested only in individuals who are intolerant to the topical formulations. Do note that the doses for oral minoxidil are essentially low, that is less than 5 milligram daily, and you need to monitor for cardiovascular side effects. Finasteride is a 5-alpha reductase inhibitor, and it reduces total serum DHT. It works best on the vertex and frontal scalp. About 66% individuals achieve moderate hair regrowth. Google the name and the internet is flooded with sexual and depressogenic side effects. This is responsible for the nocebo effect seen in most of the patients. However, a recent systematic review proved otherwise, that only in 1.5% these side effects are manifested. So the physician plays a very important educating and balancing role. Is fertility a concern? Yes, only but rarely in those who have pre-existing fertility disorders. Casserini et al. Recently proved that the DHT suppression with topical and oral forms is equal. So might as well prescribe a topical form in those who are apprehensive. Dutasteride is used off-label but is working well in those who have a plateaued or no response to finasteride. Topical ketoconazole has local DHT blocking effect. Palmetto is generally suggested in those who refuse conventional management. And prostaglandins have proven their role in vellus hair regrowth. It is always worthwhile to add nutritional supplements and topical peptides. For female pattern management, management with 5-alpha reductase inhibitors remains the same as discussed. You may use androgen blocking agents like cyproterone acetate, which is used cyclically and along with ethinyl estradiol. Then the aldosterone antagonist, that is spironolactone, which is the most commonly prescribed. Its synthetic analog, that is drospirenone, which is a common component of birth control pills. And flutamide, which is highly effective but is being replaced by bicalutamide, which has a better adverse effect profile. Now, quickly brushing through the management of alopecia areata. So, intralesional and topical corticosteroids remain the mainstay of treatment. Topical calcineurin inhibitors are prescribed often but lack evidence. Topical minoxidil is ideal for localized forms, and topical immunotherapy can be used in extensive alopecia and refractory patches. Systemic corticosteroids work best in the pulse doses. And you can, along with the corticosteroids, you may add an oral immunosuppressant or an immunomodulatory agent. Safer add-ons are excimer laser and narrowband UVB. The most exciting on the block are the Janus kinase inhibitors, that is ruxolitinib and tofacitinib. So far, they have proven to be the most efficacious as compared to any other agent. However, an early relapse, like as early as 3 weeks, is a concern in their use. Moving on to the physical modalities. So low-level laser light therapy is based on the principle of Arndt-Schul's law. That is, while weaker stimuli increase vital activity, stronger stimuli suppress it. So this principle is the same as laser hair reduction, that if you treat an area with very low fluences, it leads to paradoxical hair regrowth. The wavelength is 650 to 900 nanometers. So what is essentially low is the density of the light. That is why they are called as cold lasers. It increases the mitochondrial respiratory activity and circulation. There are no side effects that mandate discontinuation of therapy. So you can give safely 2 to 3 times a week for 6 to 12 months. Maximum penetration depths are obtained with the laser combs. And the beam with the laser cap is little more coherent and focused as compared to the LED devices. Coming to the next beauty elixir, that is platelet-rich plasma, which is just increased concentration of autologous platelets in a small volume of plasma. So we are aware of the older forms, that is leukocyte poor and rich plasma and fibrin. Of the newer forms, these are anticoagulant-free specialized tubes. Common are the growth factor concentrate and the monocyte-rich concentrate. So no wonder platelets are a rich reservoir of growth factors. And as per the golden anchorage model, they work well on the bulge area, basement membrane keratinocytes, dermal papilla, and the signaling cells. So on one hand, I'm showing off my before and after results, but it always comes with a tagline that does it really work? The reason for that question is that there is no standardization, like right from the method of blood collection to centrifugation or separation, nothing is standardized. Because of this reason, recent guidelines were given by IIDBL task force for standardization. So they recommend that the manual double spin method works the best. If you're using closed commercial kits, it is better to use 2 kits at a time so that you get an ideal plasma volume and a platelet yield. Sessions are spaced apart at a 1-month interval and works best on grade 2 to 5 alopecia. It is best to inject with deeper needles, and microneedling is no longer recommended because of the superficial depths obtained. There is no need for an external activator, and PRP is best activated naturally by in vivo collagen. The next modality is thread embedding therapy. So the indications are the same as PRP. We recommend it in cases who do not wish to visit frequently for the painful procedures. So PDO or PLLA monofilament threads are used. About 20 to 50 threads are used per session, and the sessions are spaced 6 months apart. Needles are placed at a gap of 1 centimeter square in a radial orientation. Mechanism of action is mainly mechanical transduction-induced neocollagenesis. The side effects are transient pain, bleeding, bruising, or bacterial infection.
2 minutes to go.
One must keep a watch for foreign body granulomas and keloid formation. Metavali et al. Proved that 73.3% of patients in a double-blind controlled trial benefited from the thread embedding therapy. So mesotherapy has been around for at least half a century, and hordes of cocktails are available in the market. So generally, we prescribe the telogen cocktail or the dutasteride containing anagen cocktail. Nowadays, we are directly jumping to QR678 in cases of AGA. On the left-hand side, you can see before and after results where QR678 was used as a monotherapy, and the patient was not on any nutritional supplements or minoxidil. Microneedling works on needle penetration-induced wound healing cascade. Do note that it is always an adjunct to other therapies, and it is worthwhile adding microneedling if the response to conventional treatment has plateaued. So a new frequency protocol was suggested by Dhurat et al., which was 4 sessions weekly and 10 followed by 10 sessions fortnightly. Lasers are rarely used, but they create columns of thermal injury, and this leads to accumulation of cytokines, which causes further wound healing and repair. Hair Botox has been tried with variable results. However, higher units are needed, that is around 3,000 units per session, and visible results are seen only after 4 such sessions. And there is something for everyone, so camouflage is always an option. One may use hair micropigmentation, hair fibers, scalp spray thickeners, or hair pieces. These are a few of my references. Thank you.
Thank you, Dr. Simran. That's a wonderful lecture that you've given, a comprehensive thing. You've covered all the modalities per se. And we are on to a surgical option, which is being covered by Dr. Marco and Berlusco from Florida. He's a surgeon, hair restorative surgeon. Dr. Marco, it's all yours now.
Thank you, Dr. Luthra. I'd like to take the opportunity to thank the GCS, the organizing committee, and the moderators for inviting me to give this talk. Is everyone able to see my screen here? I'm not sure.
Yep, we can.
Yep. Okay, perfect. So let's go ahead and start. So I'm going to talk about some of the updates on surgical hair restoration. It's not going to be a lecture that is going to be very comprehensive on all the individual techniques, but just an overall overview of what's been happening in the last few years and how we perform contemporary hair restoration surgery today. I have no conflicts of interest to declare, so there's nothing here that nothing I'm going to talk about here. I have any commercial interest or anything, okay? So for those of you who are not used to hair restoration surgery, all the attendees, basically, we identify the hair loss. Hair restoration surgery can be effective for a multitude of hair loss causes. Most commonly, we do hair transplantation for male and female pattern hair loss or endogenetic alopecia, although it can be used with some limitations for other types of hair loss too. So the first thing, as any procedure or any medical intervention, the right path starts with the right diagnosis, right? So once we diagnose the hair loss as a surgically treatable hair loss, then we proceed with the treatment. The second phase of a hair transplant procedure is the surgical planning, depending on the patient's current state of hair loss, his or her potential for hair loss, including his or her age, and the pattern that he or she's presenting at the moment. We devise a plan that's not only effective for today, but also always counting for future, because one thing we know is that hair loss is progressive, and we're constantly dealing with a decreasing supply of the available, what we call donor zone, which is the temporal and occipital zones, and a constantly enlarging need for hair as the patient continues to lose. So it's always important to associate surgery with medical therapy. Pretty much all of my patients are on some kind of medical therapy, as discussed before in the previous lecture. That is very important because we want to stabilize the hair loss and not allow it to progress as much as we can. The harvesting of the follicles it can be done through the traditional follicular unit transplantation, or FUT procedure, which is known as the strip procedure, which requires an incision and suturing. It's very effective. It's been used for many, many years, and I still perform it to this day. About probably 70% of my practice is FUE, or follicular unit excision procedures, and about 30% is FUT. So I still perform it very often. The second modality of hair extraction is the FUE, or follicular unit excision, where we use little punches to extract the hairs. No need for a long incision or linear incision. And there is scarring, but the scarring is usually punctate instead of a linear scar. So if done correctly, if the patient heals well, it's a lot harder to detect the scarring from the donor harvest with the FUE, allowing the patients to wear a much shorter hairstyle without seeing signs of transplant. So it tends to be very popular, but not every patients are great candidates for this. The important things, regardless of the method of harvest that we choose or that the patient needs, the most important thing is that we have adequate follicular unit grafts. So as you can see in this illustration here to the right side of the picture, you have some single hair follicular units, double hairs, and triple hairs. As you notice, there is protective tissue around the hair follicles. The intact hair is present throughout the length of it, including the dermal papilla, the bulge, the glands, the sebaceous gland. So those are adequate grafts that need to be obtained with whatever technique we choose. Then the next step is the execution, right? We have to get these hairs back in the scalp. So there are different methods to do this. The most traditional is the pre-made incisions, where the physician will make the incisions for the hairs at the adequate angle and direction in relation to the existing hairs in the scalp or to the skin in order to provide the best results. It's also important to create irregularity, particularly in the hairline. You can appreciate that here on the edge of the hairline where there's no straight lines. In this case, I rebuilt a little bit of the frontal temporal angle to get the patient a better cosmetic results. And then, so this can be done also the same way in the crown. And then the next step is the placement of the follicular units into the incisions. The traditional method has been with forceps. You can see here the grafts are resting in this storage basin on the finger, and then they are easily placed into the incisions following the angle and direction that it was previously made. At the end of the procedure, it should look like this. All the incisions are filled with the grafts. In this case, it was a female patient where we rebuilt her temples and the frontal hairline. And if done properly, it can provide the patients with extremely natural results, very nice coverage of the scalp. We can play with the angles and directions to create better illusion of density. So hair transplant surgery is very effective and very nice when done correctly. This is a close-up of a transplanted hairline, just to illustrate how natural it can look even under close inspection. So what has changed, or what are the major advancements that we've observed in the last few years in these various phases of the hair transplant? So we'll quickly discuss advancements in hair graft harvesting, in hair graft storage, and in hair graft implantation. So as far as hair graft harvesting, we've had the robotic system, which introduced some kind of mechanization to this surgery. I'm not going to go into details on this. I don't have the time for it. It has advantages and disadvantages. So if you are looking into starting hair transplantation for your practice and you're getting bombarded with all these advertisements from these companies, do your research. If you want to talk to me about it, I can give you the neat and gritty of each one. Okay. There are some automated devices for FUE extraction, like this one here, which is another type. It's basically a device that controls the rotation of the punch. This is also another one. These two devices, the last two, rely on suction to remove the follicular unit. The follicular unit is actually stored in a canister into the machine. So you can control some parameters on the punch, but not a lot of them here. This is one of the latest ones to come into the market. It's basically a microcomputer where you can actually customize the movement and the translation of the punch. So it allows a lot of customization and a high degree of specificity for the patient's scalp and skin and hair. These are just different designs of punches. I have to give credit to my great friend, Dr. Umar from California. I borrowed this slide from him. We have different sizes of punches, different diameters, different configurations that we can really customize to a patient. Normally, the differences are here on the tip. For example, this is a serrated punch. This is what we call an edge out punch, where the sharp edge is actually away from the hair. You have the slotted punch for some longer hair harvesting, and you have the trumpet punch on the right side of the slide, which has a flared end that's designed to prevent transection. All of these things, all the devices for FUE, all the punches, have to culminate into getting a graft that looks like this. This is a follicular unit, a 3-hair follicular unit that was harvested from the scalp, a close-up photo. So you see that the hair shafts are all intact. All the sebaceous gland is beautifully maintained here. There is good tissue around it. The incision is fairly small, and you have the intact dermal papilla here too. So these are our ideal follicles that you harvest with whatever method. A choice of the machine or device depends highly on the physician doing it. It's about testing them out and see what you feel more comfortable with. As far as hair graft storage, these are advancements here. When I say graft storage, means After harvesting from the donor site, they have to be stored between that time and the placement. So usually a couple of hours out of the body, we try to minimize that time as much as possible. During that time, they need to be protected. Traditionally, hair grafts are stored in cold, chilled saline solution, but I've seen people use lactated ringers, Viaspan, all these types of storage solutions for tissue transplants with various results. And so what I use in my practice, again, I don't have any conflict of interest. I'm not proposing this, but I use this solution called hypothermosol, which is a cold storage solution, is buffered, and it has antioxidants in it. So it protects the hairs, in my opinion, against damage. You also can add this liposomal ATP solution. It's called ATPV. It's basically encapsulated ATP into liposomic molecules, and they deliver the ATP to the cells with various degrees of success. Advances in hair graft implantation. So traditionally, as I mentioned before, implantation has been done with pre-made incisions and forceps to slide the hairs into the sites. In the last few years, we've had the ability of doing that with implanter pens. So this is one of them. There are multiple designs out there. These pens, what they do is you're able to load the graft into the tip of the pen and then use the pen to make the incision and then place the hair at the same time. They have limitations, they have advantages and disadvantages, but they can be useful in your practice. A friend of mine from Brazil actually came up with the idea of actually using dull implanters to place grafts into pre-made incisions. And so you can use that if you make your pre-made incision, so your staff can use the dull implanter. So they're not actually making the incision with a sharp implanter, which should always
2 minutes to go.
be handled by the surgeon, but they actually use the dulls to place. This is another design, but basically what they do is they serve the same function here. You can see the hair graft loaded into the lumen of the needle. There is this channel here. You basically incise the skin of the needle and you drop the hair in there. With implanters or without implanters, the most important thing is to get a surgery that you can get the patient good density, natural results. This is a picture of a close-up of a post-op patient. And, technology is great. That's my final message here. But a successful hair transplant procedure requires a well-trained surgeon, not a well-trained technician to perform it, and an experienced team. You cannot do this by yourself. So if you're contemplating starting into hair transplant, talk to us, experienced people around the world. I'm sure we'll be happy to train you on doing it appropriately. Be careful with promises of turnkey solutions to your practice, because a lot of that comes with a high price to pay as far as patient results. So this is it for me. I appreciate it again, and I'll take questions at the end if needed. Thank you.
Dr. Marco, thank you very much for a very elegant and a very timely lecture. I'm sure there's going to be lots of questions for you. We just need to go back to the main screen. Wonderful. My name is Dr. Tapan Patel. I'll be introducing the remaining speakers. Thank you very much for what you've done also, Amit. It's a thrill and a pleasure to introduce the next speaker because she's a personal friend of mine. Dr. Simil Soin is based in Delhi, and the last time I was there, she treated me to a very elegant lunch, which just thinking about it makes my mouth water. Dr. Soin has been an expert in the field for over 18 years and has also done some training in London and Cambridge. She's a respected name in the field of aesthetics and cosmetic dermatology and will be speaking to us about cosmeceuticals and hair cosmetics. Over to you, Dr. Soin. Can we get Dr. Soin up?
I think you're muted.
Oh, really? Okay, hi. Hi, Tapan, thank you for the introduction. Can you see the screen? Can everyone see the screen?
Yes.
And can you hear me?
Yes.
Absolutely.
Okay, lovely. Hi. Pleasure to be here with you all. I said now a little more colorful presentation in keeping with my topic with the yellows and the pinks. So I am Simil Soin. I run a chain of clinics called Aina. Aina in the Indian languages means the mirror or reflection. So I'm going to speak a little bit about hair cosmeceuticals. So the way that I would define the cosmeceutical is it's a skin or a hair care product that has a high concentration of bioactive ingredients and combines the elegance of the cosmetics with the efficacy of the medicines, but in a gentle, usually manner without usually any undesirable effects. And the gentleman, Albert Kligman, who introduced cosmeceuticals, said that it was a product which basically exerted a pharmaceutical therapeutic benefit, but not necessarily a biological therapeutic benefit. And the interesting thing now is that although the word cosmeceutical is steeped in dermatology literature, dominates academic discussions like we're talking about it now, symposia and lectures, it's quite strangely interesting to note that after so many years of the coining this term, the skincare product is still not formally recognized by the United States FDA or the European Union. And this was interesting because when I look at the way hair has now gone, I would call it skinification of the hair, even for the last few years, but more so last year with COVID. There's a plethora of products all over the place, online, over the counter, promising the earth. And I do believe that as dermatologists, we need to open our mind to products beyond what we already used to. And the reason I started, I have to say, using more cosmeceuticals in my practice is because most patients who came to me would have used minoxidil for years, were skeptical of taking finasteride. So I've usually had to work around that. And that's when I started using cosmeceuticals a lot in my practice. And I have to say the results have been nothing short of satisfactory, in fact, quite good. So the new trends in hair care that when I was looking for, this is what I found. The range of peptides to hair oils for cuticle and strand nourishment. There's dramatic increase in searches for plant-based shampoos worldwide, and 330% increase in hair loss product searches last year. Increased interest in vegan, silicone-free shampoos and natural and clean products. And hair masks for home use are in because people like the feel of an intensive treatment. Although personally, I think it's very messy. Then interest in antibacterial hair care and focus on scalp care. I suppose everyone understands anchoring is important. So, so natural and clean in my mean different things. Natural does not mean it's synonymous with efficacious in my view. Clean means that the body should be able to process, accept, recognize, and successfully use it without any irritation, sensitization, disease, or disruption. And clean, in my view, can be synthetic or natural. So with cosmeceuticals, we are back to nature in more ways than one. Case in point, I have to say QR678, derived from plant growth factors. In my view, the way that we're working now with it has come like a holy grail for hair loss and scalp care. And I know we'll be talking about it later. Safe, effective, and quick. I was in fact one of the first people to start using it in North India. And it's a huge comfort to have a product like that. And the reason I feel people are veering towards science-backed phytoformulations, and I say science-backed, is because they want to avoid chemicals and their side effects they perceive and to minimize the carbon footprint on the environment. It's also important for us to note that clean doesn't mean that you need to go 100% natural, because a lot of synthetic ingredients are also safe. And we all as doctors, anyways, we would support science-backed skincare. Some ingredients in the lab can deliver perfectly good results. Then anyway, so talking about going back to nature, each of the actives found in the new hair cosmeceuticals are primarily derivatives of plants. We talk about Redensil, Procapil, Kepixil, Anagain, saw palmetto, caffeine. Aminexil is not, but Bicapil is another one which comes from wheat sprouts, soya extract, and a purple flower extract called Bicapil. So Redensil is another very popular bioactive in hair cosmeceuticals, now with extremely encouraging results, I have to say. So it targets the hair follicle stem cells, triggers the anagen phase of the hair cycle, while also preventing the telogen phase of the cycle, meaning that the hair has a longer period of growth before its follicle rests again. So this is one of the few studies which compared in Turkey on 120 patients, which compared Redensil, Kepixil, and Procapil combination with topical minoxidil, and it showed greater patient efficacy and patient satisfaction. Procapil increases scalp circulation and acts as a DHT blocker. Anagen is an other very popular product now that I find in hair cosmeceuticals, which activates in the dermal papilla specific signal molecules which are required to initiate the growth of a new hair. This will shorten again the resting phase of the hair, prolong the growth phase. So pea sprouts are a rich source of biotin, arginine, and isoflavones, very well tolerated both topically and as a food supplement. So saw palmetto, we're all quite familiar with very finasteride-like actions. It's used topically and as an oral supplement both. I've never given it as an oral supplement, but it's there in a lot of cosmeceuticals we use. So it prevents conversion of the testosterone to DHT by lowering the 5-alpha reductase, and it blocks the androgen receptor. So it's very like finasteride. Besides hair loss, it also improves testosterone levels, reduces inflammation, and improves prostate health in men. This was another study I found in the base. I couldn't really find many studies on any of the hair cosmeceuticals, which interestingly, considering we're using so much of them. But Bicapil was a pilot study which came from Hyderabad in India, which had a lot of efficacy in the treatment of telogen effluvium. And now a bit about peptides. So this is the latest skincare ingredient to have crossed over into the hair care sphere. Not like a hair filler. Peptides are highly effective in hair care because they are so small that they penetrate the hair follicle. So when they do that, they basically increase moisture and prevent breakage and make the hair thicker. They contribute to better hair growth because they increase the diameter and the elasticity of the hair. So good for even damaged and combination hair. So I have to say that for dandruff, for scalp dandruff, I haven't found many hair cosmeceuticals useful, but I do sometimes prescribe cosmeceuticals, the shampoos other than the usual ketoconazole and the coal tar ones that we use, because they tend to be extremely drying and cause frizziness. And with the hair cosmetics, my God, it's a large, large universe there. And I have to say that most of us obviously only have a working knowledge of it. So essentially, I would divide them. They're divided into ones which work on the cuticle and ones which work on the cortex. The shampoos, the conditioners, the serums, the hairsprays, the waxes are all on the cuticle. And those which dive into the cortex, the hair color, the bleaching agents, the straightening and the perming agent, causing all the damage is basically the ones which go into the cortex. And so while we talk about this, there's another product that I've noticed is been very useful is something called Olaplex, which is, as dermatologists, we're possibly not even aware, but I have a little hair place where people actually get their hair wash treatments done. So Olaplex, although it's been quite a lifesaver for people who have damaged hair through hairstyling, through rebonding, through perming, straightening, and coloring treatments. So although not very well researched, but it's present in most countries of the world, and it has some great reviews. These are some recent additions which I found to the hair cosmetic world when I was searching for it. And this argan oil is very good for nutritional benefits for the hair. Then there's development of something called dry thermal energy to transfer a color into the hair shaft to avoid messy liquid dyes. These are all sort of new innovations, I suppose, and incorporation of alpha hydroxy acids into hair products to bring down the alkaline pH of hair products, and use of something called glycine to make hair volumized, soft, and manageable. And the complete no-nos are parabens, fragrances, aluminum compounds, all of these, which we know are complete no-nos. And there is a lot of people, they are now not used so commonly in the products that we are using now. So hair, I believe in large part has been viewed as a cosmetic issue more than medical. So academic funding bodies nor industry haven't really spent significant amounts on research, which is why we don't have so many studies here. So I don't think I would be exaggerating if I say that about 30–40% of the dermatologist prescriptions across the world consist of cosmeceuticals. So while it's not really life-threatening like a cancer or heart disease, but it is an important instrument of social communication. And looking at how extensively we use these products in doctor practices, clearly we need more research in the hair cosmeceutical space in order to have solid science back our offerings and have better patient compliances. So our clinics don't offer hair transplant. So a typical patient with hair loss will be offered a QR678, which we do actually
2
use
minutes
a
to
lot
go.
now. With or without a PRP. We used to do PRP quite extensively, but now we combine both of them, or we use QR678 just by itself, but we do not use PRP now actually just on its own with the coming of QR678. Then we write a hair cosmeceutical or a minoxidil, depending on where they are in their journey, and an oral supplement, or finasteride not so often anymore, actually. Thank you all so much.
Tapan, you're on mute. Tapan, you're on mute.
Apologies for that. I just said, Dr. Soin, thank you so much for a very detailed and comprehensive talk and sticking to time. In the interest of time, I will move swiftly on and introduce the next speaker. A retired squadron leader with the Indian Air Force, Dr. Aseem Sharma, is now Chief Dermatologist at the Skin Saga Center for Dermatology in West Mumbai, and will be speaking to us on a critical review of PRP, growth factor concentrate, and other mesotherapy solutions for hair loss. Over to you, Dr. Sharma.
Thank you so much, Dr. Tapan. Is my screen visible in full?
Yes, it is, indeed.
Yes. So thank you so much for that introduction. Now, PRP has evolved as a very humble hematology concentrate, as all of us know, to something which, if I can use the phrase, has broken the sonic boom in the field of aesthetics. How it has done so, we'll see in the next few slides. So much so that we now have something known as doorstep PRP, where PRP would be delivered at your doorstep. I really hope that trend does not catch up in India, because we do seem to follow trends quite fiercely. The important thing here is, before I jump into scientific data on why we use it and whether we should use it or not, most of your patients are Googling how to, whether they should take PRP or not, and where they should take their PRPs from. Over 800 million hits per day is what Google tells us about people Googling PRP and alopecia. So definitely patients need it. As dermatologists, we are very, very fond of our platelet-rich plasma. We use it in androgenetic alopecia, alopecia areata, cicatricial alopecia, skin rejuvenation, to more demure conditions like lichen sclerosis, vitiligo, and melasma. So what I'm here to give you is a critical review of platelet concentrates and their extended family. So if PRP works so well, if patients are demanding PRP, why is there a dilemma? Why has PRP become the electric controversy of the last decade? Now, all of us who are dermatologists know Cochrane to be the Bible of dermatology. They came out in 2015 and said PRP therapy is off-label and must await robust evidence from clinical trials. So PRP over the years has been misrepresented, blamed, negated. Not only Cochrane reviews, but many articles stating that it's no better than placebo. Cut to 2022, do we finally have data which negates that? What does science say? So the current level of evidence, all of us are aware that S3 guidelines are European guidelines for many dermatological conditions. As of 2018, they came out with recommendations for AGA in women, which is female pattern hair loss and male pattern baldness. What they said was that PRP holds a level 3 of evidence for androgenetic alopecia and a similar level for female pattern hair loss. What we should be asking ourselves is, why only level 3? When 74% of the studies show an improvement in hair from baseline with various outcome variables that they tested. The problem here is with the heterogeneity in measurement variables. Outcome variables are not standardized. The preparation method itself is not optimized. The outcome variables are not adequate. The studies are more qualitative than quantitative, so it's difficult to conclude what level PRP would be at. However, 2022, we do have 26 randomized controlled trials. You heard me right, 26 RCTs of the usage of PRP in androgenetic alopecia and 3 studies in alopecia areata. So that itself should settle the question of whether PRP works in AGA or not, or for alopecia or not. So the problem here is we do need more robust data because we are evidence-based learners, but we also need to align expectations, not only of patients, but also of doctors. For example, if patients are expecting to look like Jason Momoa and you get some random bloke, of course, they're not going to be happy. So are we expecting too much from our PRP? PRP is definitely the elixir for alopecia, but it's never a standalone therapy. A lot of articles mention the usage of PRP as a standalone therapy without anything else. See, we have to understand, when androgenetic alopecia or male pattern baldness or even cicatricial alopecia, when these are conditions which have a multifactorial pathogenesis, how can we support it with one single treatment? You have to target all the pathogenic mechanisms that a particular disease has. So herein lies the concept of marginalizing expectations with reality, which is the most important thing that we need to do so as to prove that PRP really works. So PRP does work, but how are we doing it? What are the methods that we use? There are open and closed methods. The open method is the double spin PRP method, which is a gold standard. Closed methods or commercial kits are also used quite heavily, but they totally depend on the yield. So in descending order of yield, you will see kits like Kyocera and Magellan, both are not available in India. We have Arthrex, which is a medium yield kit. We have Regen and Dr. PRP, which are low yield kits. Gel separation tubes, as all of us know, are the lowest possible yield. We do it for ease of convenience. All of us do it, but it's definitely not the recommended thing to do when we are doing PRP. In fact, all of us who are doing PRP, or all of you, in fact, who are doing PRP, should refer to a DEPA classification by Magellan et al. They have classified kits, commercial kits, and standardized and non-standardized methods for preparing PRP by the dose, the final dose of platelets in your injection, the efficiency of the process, the preparation process, or how many platelets you are losing in the recovery process, and the final purity of your concentrate. So as I showed you in the previous slide, Regen kits are low dose kits, Arthrex is medium dose, Magellan and Kyocera are high dose kits. So that should settle the the logic behind using commercial kits or closed methods instead of open methods. We'll move on to second generation concentrates, but before that, two honorable mentions. My mentor and the reason I'm in this field, Professor Rachita Durar, does profess heavily and prophesize heavily the use of temperature controlled PRP, which has been proven in many studies that if your temperature during preparation is under 20 degrees for the first and second spin, you will avoid unintentional activation of platelets and you will get a better yield. So that is something which I wanted to put out there. Another mention of TPRP, titanium PRP, and I'm not referring to the song by Sia. Titanium is a very strong activator of platelets. So a speaker earlier had mentioned about not activating our PRP anymore. I totally agree with her. Glass itself is a good activator of platelets. Most of us use glass tubes. And if anybody gets access to titanium tubes, then those are very strong activators of PRP. So just on a lighter note, I wanted to throw that out there, that there are two types of TPRP. So let's move on to the extended platelet concentrate family. Now we've spoken about first generation concentrates, which are PRP. There are second generation concentrates now, which are platelet-rich fibrin. We use the injectable form in alopecia. You have growth factor concentrates, and we have hyperacute serum. And we have outstanding members, which are mesotherapy solutions and concoctions, which I'll touch upon very briefly at the end. So what happens with second generation concentrates? They are single spin methods. No anticoagulants are used, and they use a fibrin scaffolding around the growth factors, which is why the growth factors last for a longer time. All of us doing PRP know the growth factors last between 60 to 90 minutes. But in the case of second generation concentrates, because of the biomechanical scaffold, they extend for about a week to 14 days. So this is the Gen Next. Advanced PRF is something we use in wound healing, and a lot of oral maxillofacial surgeons use. We don't use it in alopecia as such. We have concentrated growth factors, and we have injectable PRF. So injectable PRF was made famous in 2015 by Mauro et al. It's an injectable form of platelet-rich fibrin or a second generation concentrate. The concept here is to use an ultra short centrifugation RPM and duration. So slower speeds, shorter centrifugation time gives you a higher concentration of growth factors. And this is the latest when it comes to androgenetic alopecia. But does it appeal to our scientific bent of mind? Unfortunately, there's only one case series, not even a trial or an original article which has been done on IPRF. I'm awaiting good evidence on this. And maybe I will mince my words in subsequent hair talk sessions. But as of now, as of Jan 2022, PRP trumps over injectable PRF any day. Moving on to concentrated growth factors, I know I get a lot of questions on a daily basis on CGFs or GCFs, which are used interchangeably. The original one was made using a Medifuge centrifuge from Italy. They claim to have a denser matrix, so they target the extracellular matrix as such, the anchoring model of the hair, along with giving growth factors. The growth factors themselves are claimed to be 3 times more than you get in regular PRP, therefore giving this particular concentrate the maximal regenerative capacity. Heavy usage in facial volume loss and advanced AG is what they claim. In India, we get them as Walk-Hard kits or Folly-Rich kits, and 2-3 other companies which have come out with the kits. Again, no conflicts of interest here whatsoever, as you will see in subsequent slides. Again, Does it appeal to our scientific bent? If you look at the efficacy of PRP and concentrated growth factors, this particular study, retrospective it was, they had a large sample size, but they used a combination of PRP with CGF. Another study where they used a combination of CGF with topical minoxidil, and they proved that the combination is better than topical minoxidil alone. No controlled arm with PRP. Again, I'm going out on a limb here by saying that I would still prefer PRP over CGF as based on today's studies or studies we have until today. Again, there's a rider here. We are all academicians and practitioners. So if somebody has extreme pain to PRP, PRP does tend to be a very painful procedure, not only on the face, but also on the scalp. If I'm short of time or people who have busy practices, I would probably concede to using CGF in alopecia, but PRP would always be my first line. I would always consider a concentrated growth factor as a second line if a patient cannot tolerate PRP. There's another thing in the offing called hyperacute serum. Now, anybody who's, any plastic surgeons amongst us who've been dealing with wound healing would know what I'm talking about. Once you remove the fibrin clot in a second generation concentrate, there is this serum which is left, which is very high in inflammatory markers. That's called hyperacute serum. There are no studies as of now in the field of alopecia, but maybe in future we will have something, to do with hyperacute serum. So just wanted to put it out there. There is some research going on in this field as well. With that, I finish my platelet concentrates. I'm going to move over to mesotherapy. And literally speaking, if Shakespeare were alive today, he would have asked this question: to use or not to use mesotherapy. So the principles of mesotherapy include, solutions
2
which
minutes
have
to go.
Yes, I'll be wrapping up soon. Thank you. So the solutions range from 20 to up to 60 to 100 ingredients as well. They are principal ingredients and complementaries in the particular concoction. What is the issue then with mesotherapy? The issue is with FDA regulation. The issue is that these are cosmeceuticals vis-a-vis drugs. They don't have drug licenses. Ask any of the mesotherapy solution holders, or most of them especially, they will not be able to provide a drug license for it. So are we safe to inject a cosmeceutical into the scalp? That is my beef with mesotherapy solutions. So can we do it? Definitely. Should we do it? We definitely should. There is enough science behind it as well. But instead of using an injection to inject something which is not a drug, but a cosmeceutical, which we have no idea about, it's better to use a mesotherapy gun, in an electroporation device or a mesoporation device, phonophoresis or iontophoresis, microneedling systems. And a good friend of mine from Rhode Island does tattoo machines. He uses tattoo machines to deliver dutasteride as the monotherapy solution into the scalp. Those can definitely be done, but let's not inject, at least as of now. For more reading on platelet concentrates, Professor Rachita Durat had pioneered work in PRP when she published her work on methods of preparation of PRP. This article has been cited more than 650 times, the highest possible citation for a trichology article. And closer home, we also took out guidelines as a national association on how to use it and optimizing the use of PRP in androgenetic alopecia. So do go through these articles for more reading. Since I'm not meeting all of you in person, stay home points from my side. There is a definite perceived therapeutic need gap in alopecia. Procedures are never an alternative to medical therapeutics. Let's get that fact absolutely straight. Alopecia's multifactorial treatment has to be via combination. Evidence-based learning is the way forward. What to use where remains the key. I am very thankful to IAFCS and the Global Cosmetic Surgery for having me here as a speaker. And thank you very much, audience, for a patient hearing. Back to you.
Dr. Aseem, thank you very much. You covered an enormous amount of information and you did it very comprehensively in such a short time. So thanks. Now, the next speaker is Dr. Rinki Kapoor, and she's a consultant dermatologist, cosmetic dermatologist at the Aesthetic Clinics and Fortis Hospital in Mumbai, India. She's actually going to be talking about a novel biomimetic peptide growth factor solution for hair growth, but I've been informed she's experiencing some problems with her internet connectivity. So accordingly, we will be actually playing a pre-recorded video. So over to the technical team to start her presentation, please.
Yeah, thank you, Dr. Patel. I hope I'm audible.
So sorry for this because I have some issues with the internet connectivity here, but nevertheless would like to say hi to all my colleagues. There are a couple of my mentors and teachers in this forum today, and it's been a really enriching experience to hear all their talks and presentations. As we've had some of the speakers talk about robust scientific evidence and clinical data, which should be available to support the treatment modalities and the treatments that we offer to our patients, because we as clinicians are scientific people. And so let's see what this novel formulation has to offer us, which I think is the next paradigm in treatment of medical treatment of hair loss. And I think Dr. Simal has already touched on this topic earlier in her talk. So I'll, without wasting much time, I'll hand over the presentation to Arundha. So Arundha can please run the presentation for us. Thank you so much. Hello, everyone. It's a privilege to be here today and to present to you a novel biomimetic peptide growth factor solution for hair growth, which I think is the next revolution in medical hair care. Now, this invention has a United States patent, an Indian patent, and is FDA approved in 10 plus countries across the globe. And I'm a researcher and advisor to the parent organization. Now, hair loss is a global concern, and we all know that. And the global hair care market is one of the fastest growing segments in aesthetic medicine. Now, hair loss is not just a cosmetic problem, but it's also turning into a mental health issue, which is very well seen in this particular paper that has been published by the Aesthetic Clinics in Dermatological Reviews this very year, which mentions that alopecia it follows an iceberg phenomenon, wherein actually the clinical symptoms that patients present with to the physician are actually just the tip of the iceberg. And the majority of the problem, that's the psychosocial aspect of the disease, is the larger part of the iceberg that's under the water. Now, many treatments available, for example, your age-old topical minoxidil and finasteride, invasive therapies like hair transplants, stem cells, and platelet-rich plasma, and so on. And we all know that there's no universally effective therapy for all forms of hair loss. So the problems could be something like unpredictability of results, side effects, expenses, and invasiveness of procedures, and all the more a couple of procedures like the PRP, stem cells, etc., do not have enough peer-reviewed evidence-based scientific literature on their use in hair loss. We also have problems with patient compliance in such procedures, because in today's fast-paced world, if the patient is spending an hour to travel to your clinic, and then he sits in the clinic and gets his blood drawn and then centrifuged and then injected, that's taking another 1 hour, and then there's pain and there's downtime. So, and you're expecting the patient to come every couple of weeks to the clinic and spend 2 hours of his time on this, then somewhere down the line, patient compliance is really, really getting affected. At the same time, it's also a burden on the time of physicians as well as patients. So we really need something that is easy on the patients and the physician's time, that is easy in terms of no downtime, which has no side effects, and at the same time gives really good results. So this is something like what Henry Ford said when he invented the first car. So what he said was, if he had asked consumers at that time what they wanted, they would have merely said they wanted a faster horse, because nobody knew at that time there could be something as good as a car that could be available. It's similar with hair care therapies. So there have been physicians who've been using things like PRP and medicines and stem cells for a long time, because that's what was available to them. And they haven't thought out of the box. They haven't thought of getting something better than a PRP. They just think, probably give me something which is a better PRP, when there's something much better than a PRP or a stem cell that can be available. So basically, we need something which is not old wine in a new bottle, but we actually need new wine in a new bottle. So that's precisely the reason why the QR came into being, to overcome barriers, challenges, and uncertainties in currently available hair care therapies. Now, when I was doing my residency and a couple of years thereafter, these were the only therapies that were available. And there were a huge lacunae in treatment that were available at that time for treating hair loss. So that's why the QR, that's how the QR was born. And now what is this QR 678 Neo? It's a bottle that contains sterile 5 ml solution of a unique composition of hair growth factors in the right concentration, which has been developed after years of research. Now, the benefits of using the QR is that it's cost effective, it has more than 90% success rate, it's plant derived, so it has zero side effects. And now let me take you through the entire composition of the QR678. So this is basically a composition of 6 hair specific growth factors which have been researched over a period of time and in the right concentration delivered at the right target, which is the hair root. Now, what are these 6 growth factors and what do they actually do? Let's see. For any hair loss therapy to be really effective in different causes of hair loss, it must provide a certain couple of basic treatment targets, basically stimulation of anagen, increase in angiogenesis at the hair root, then prolongation of anagen phase. It should inhibit 5-alpha reductase, that's the hormonal component, strengthen the hair shaft, and reduce inflammation. Now, as we all know, androgenetic alopecia is now considered more of a chronic inflammatory disorder. So you need something that also targets inflammation. So if a hair care therapy can do all these, a lot of your job is already done. Now, what is exactly happening? So this is a pictorial representation of where the growth factors incorporated into the QR work in the hair cycle. So you look at the bottles of the QR here, it improves the hair shaft, the strength of the hair shaft. You see those yellow boxes down there at the hair root, which are the hormone receptors. It works there. Then you come to the catagen phase, there it works on improving the blood supply. Then when you go to the telogen phase, it starts working on the stem cell bulge region of the hair follicle to stimulate anagen. And then the last bottle you see there on the arrow between telogen and anagen is basically prolongation of the anagen phase. Now, I want to tell a couple of indications wherein the QR has been found to be hugely successful. Male pattern hair loss, even stubborn cases not responding to traditional line of therapy. 8 sessions, 10 sessions down the line, marvelous results. Polycystic ovarian disease associated or hormone associated hair loss, basically female pattern hair loss, marvelous results. Post hair transplant hair loss. Now, after a hair transplant, if you do not treat the non-transplanted hair, they continue to fall. Hence, you do need maintenance for those hair, which can be marvelously done with the QR678. Alopecia areata, stubborn cases, recurrent cases, traditional line of therapy in addition to the QR, excellent results. Post-COVID hair loss, nowadays patients coming with bunches of hair in their hand, crying for help and saying they would get bald within a month's time if not treated. So post-COVID hair loss, excellent results with the QR. Post-chemotherapy hair loss. After chemotherapy, most of the patients regain their hair. However, there are some who get into persistent alopecia. So to stimulate the dormant hair roots, the QR is very effective. Patients who do repeated chemical treatments on their hair, it's a professional demand for them. Patients who are celebrities in the social media, airline people, they all do a lot of chemical styling, etc. on the hair. So for such patients, for prophylaxis, for hair rejuvenation, maintenance of the hair, it's extremely beneficial. We've also recently started getting wonderful results in advanced cases of androgenetic alopecia, force in combination with traditional lines of therapy. Now, this is how the treatment is done. You would be amazed to look at the simplicity of the therapy. The patient walks in, sits into the chair, doesn't need any local anesthesia. You draw the 1 ml of solution into the syringe and do section the hair, do a couple of lines vertically, couple of lines horizontally with the Napaj technique. There's no bleeding, there's no pain, and the patient walks out in 15 minutes flat. One patient of PRP needs about 1 hour of time in the clinic. In that 1 hour, you can do 5 patients, believe me, with the QR678 at no downtime and no pain and marvelous results to go with. Okay, so that's how it is done. the patients can just get back to work. It's basically a lunchtime procedure. Now, this is the most important part of the presentation, evidence-based scientific literature on the QR678. Initially, animal studies performed to prove the safety and efficacy published in the PRS. Then we did a pilot study in 1,000 human patients, which was published in the Journal of Cosmetic Laser Therapy, wherein 1,000 patients with AGA treated to get increased volume, better density, and reduction of hair loss. Thereafter, this was very important for us to compare it with existing modalities of therapy, wherein QR was found to be 3 times better than the PRP with minimal side effects. And this is something that I want each one of you to read, basically a review of literature with regards to the PRP published in Dermatology Online 2018, which basically states that till date, despite the PRP being around for almost 15 years, there's no widely accepted definition of PRP. We actually do not know what is the right concentration of platelets that should be there in the PRP to give you the desired results. So, and the studies which have been, very few studies which have actually been done are cities which are available with the PRP, and all of them have a problem. There is huge amount of inter-patient and intra-patient variation. Now, if I'm doing the PRP in you and in me, the concentration of platelets is different in both of us. So therefore, the growth factors that we are getting through the PRP is different. So the results have to be different. Even in the same patient, if I'm doing a PRP today, then I do it after a month, I do it after another month, the concentration of platelets on no 2 days is going to be the same. Therefore, the growth factors that I am receiving in every session of the PRP is different, even in me myself. So a huge amount of variation there. And also there is a problem with standardization of PRP protocols, problem with standardization of preparation, of injection, of the choice of activating agents, the number of sessions, and so on and so forth. That's precisely probably the reason why PRP still doesn't have FDA approval for treatment in hair loss. It still doesn't have a patent. And there's another scientific conflict that's recently come up, wherein a couple of growth factors present in the PRP seem to have an inhibitory effect on certain stages of the hair cycle. Now, this is a comparison I would like to show you between the QR and the PRP. A QR is standardized therapy. The concentration of growth factors, the method of injection, frequency, etc. is standard across patients. PRP, there's no standardization. QR has robust clinical data supporting it. It has been found to be 3 times more efficacious than the PRP. It's targeted therapy only for hair growth. It's not like the PRP. PRP is being used from, it's being used in orthopedics, in dentistry, in treatment of skin ulcers, and skin rejuvenation and whatnot. So it's being put in anywhere and everywhere. Basically, jack of all trades, master of none. The QR is safe and easy to use. It's quick to use. No inhibitory growth factors. No investment in any device. You do not need any sort of device, no centrifuge, etc. There's no biohazard. You don't have contact with body fluids, negligible side effects, and last but not the least, is patented and FDA approved. Going forth with the publications with the QR, efficacy in female pattern hair loss with PCOS, efficacy in post-chemotherapy induced hair loss, efficacy in severe stages of androgenetic alopecia with combination of minoxidil and finasteride, and efficacy in also treatment of recurrent alopecia areata. We've discussed all this. These are just the published literature. It's available on PubMed. Anyone can have a look at these studies. And efficacy in post-transplant hair loss. Basically, after transplant, 2 months later, you start the patient on QR678 for the maintenance of the natural hair with marvelous results. And this is the latest study in post-COVID induced hair loss with the QR678. So this has just been published this year. We also have this treatment in bariatric surgery, post-bariatric surgery hair loss where telogen effluvium can be treated with the QR. And last but not the least, the phase 4 clinical trials are complete with multi-center and multi-ethnicity clinical trials through the Indian subcontinent. So these are just the milestones in development, where it began with research at the IIT Mumbai, which is a premier technology institute worldwide, from where it started. And then we had the animal trials, the human trials, the patents, and the FDA approval, and thereafter the European and the UK launch, which happened this year. And 1 lakh plus patients treated globally, being trusted by doctors, and the count is just increasing. So I thank you very much for a patient listening, and I really, really hope that you will give the benefit of this therapy to a huge number of patients of yours who require such a therapy in treatment of their hair loss. Thank you so much.
Dr. Arinki, that was absolutely fantastic, brilliantly delivered, and you did it at breakneck speed. I suspect your talk is going to generate a lot of interest and a lot of questions, but we'll move swiftly on. Now, last but by no means least, I began the session by introducing a friend. I end by introducing what I can only describe as a mentor. If you don't know who Dr. Michael Gold is, you're probably on the wrong webinar. I've only been given a minute to introduce the speakers, and that's just not going to be long enough. So all I can say is that, Michael absolutely needs no introduction. He really is very much someone who's been ubiquitous in the aesthetic industry. He has been the scientific board on so many symposia across the world. He runs a brilliant session in Nashville, Tennessee, where he's based, called Scale, a meeting I've been honored to attend at. And he will be speaking to us about recent advances in hair loss solutions. Dr. Gold, over to you, sir. You might be on mute.
You might be on mute, Dr.
Yeah,
Gold.
unmute, Michael.
So it's my pleasure to be here, and I have learned a ton this morning, which is always a great thing. And probably some of you, if you're listening, are going, "Why is Michael Gold doing a hair symposium?" Well, I'm part of a lot of them for various reasons, but I also try to tell people. My first day of dermatology residency, I actually did a hair transplant. So that was about 35 or 36 years ago, and I've been doing them ever since. I'm sort of not known in the hair transplant world, but I do have all these things and do this and do everything here except the QR thing, because we don't have it in the US. These are my academic appointments, and at the bottom, the journals that I am the editor of. And I really wanted to share with you, I have a few conflicts of interest just because I work with a lot of companies in this field, that, this is a huge problem. This, and this is just showing some of the US issues, but it's a global problem of people wanting hair restoration. But in people's identity, self-perception, the psychology of the patient, and again, without what you all showed and discussed, we would have so many, more people with decreased self-esteem and personal unattractiveness. And so again, you've all covered this non-surgical and surgical hair restoration in an incredible manner this morning. For me, evening for you in India. But I want to share with you a couple of different things. And again, this perception, this worry about concern is really, really important. So I'm going to show you some things you don't have outside the US, and some things we don't even have in the US yet, that I've been working with. And this is just a potpourri of just some thoughts and things that I'm using. So this is a hair company called Virtue, and again, it's been designed as a treatment that we offer for our patients, and basically it comes from Duke University, and where the scientists isolated an alpha keratin 60 kilounit clinical protein, and sort of together this alpha keratin gamma keratin complex, they were able to show repaired and nourish the scalp. And again, it's an over-the-counter type of treatment. So but there are plenty of clinical studies that they've done at Duke. And so again, just to show you that we can use some of these adjuncts in all the different types of hair loss that you all described today, to give our patients something to use at home. And I think one of the things that I was taught very early on in dermatology, busy hands are happy hands. That was an expression my chairman told us over and over again. So despite what we do in the clinics to these people, and to improve their hair loss, giving them something to do at home is really important. They have to be engaged. They have to be part of what we do. So again, I do that a lot. Obviously, you've covered all of these things in your talks, and I'm not going to spend a lot of time going through it, but this is also a really nice review article that was in QTIS to go over the non-surgical hair loss world. But I want to introduce you to a new medicine. So this is clascoterone, which we do have in the US as a cream for acne. But at the same time, again, it has an FDA approval for acne, but it does not yet have an FDA approval, and the US clinical trials for androgenetic alopecia have not yet started. But taking it into a different percent into a solution, in Europe, they've done phase 2 clinical trials in male and females with androgenetic alopecia. Again, it's a higher concentration, a different vehicle, and they have shown some efficacy here with it. So again, they're looking at a new topical androgen receptor molecule, reduces hair miniaturization, reduces dermal inflammation. So again, they've done 7.5% concentration, phase 2 dosing range study in males. They're planning to do at some point, hopefully this year, a phase 3 multi-center US and Europe. Again, sort of how we have to do phase 3 trials now with 2 identical phase 3 trials that'll go on again in US and in Europe to look at males with androgenetic alopecia, and again, looking at patient-reported outcomes, which is also now part of most of the FDA phase 3 trials. So what was this data? So again, this was a 12-month, this was done in Germany, 12-month randomized double-blind vehicle-controlled trial, randomized at lots of different doses, looking at 2.5%, 5%, 7.5% in vehicle, and again, looking at this for a long period of time. Change in hairline, baseline in non-vellus target hair counts at 12 months, looking at hair growth assessments and total characteristics. So again, this was sort of the design of the study. 404 patients were enrolled, 375 per protocol, in 5 parallel arms. And when you looked at the timeframes and change in hair counts, they did show some significance across the board. So that was really nice. The hair growth assessment also showed some efficacy that was very positive. And as you can see by the photographs, again, very nice clinical results, very few, if infrequent, not serious adverse events. So 7.5% solution twice daily was selected. Again, they're looking at females with androgenetic alopecia as well. And again, looking similar data, looking at different strengths of the medicine. And again, sort of looking at how this is done, again, in a phase 2 center, with comparing it to minoxidil and comparing it to vehicle, again, showing that it worked, but it didn't work as well in this case against minoxidil. So they're still sort of figuring out where to go with this and what to do. So I just wanted to sort of bring this to you as something that we may see. You had a great talk on low-level lasers. I want to share with you just one in particular. Again, people that know me know I love home devices, and I speak on home devices. And we know this works, but what we've seen in the home world, which I think is fascinating, is smart home devices. So this is a smart home device. It's a company called Revvion. Again, I have no interest in any of these companies. I just sort of I do work with them, but I don't own any stock or anything in any of these companies. And again, I think this is neat. And they've done sort of studies. This is a dual light. It's red and orange together. And Rodney Sinclair, many of us know from Melbourne, did some of the original work on this, showing that this worked better than some of the red lights alone. It's red and orange. So again, just some clinical work here. on how well it's able to function. And again, this is smart technology, so it's all done through a smart app on your phone. And I like that technology. Also, I do a lot of laser work, and this is Lutronic's device. It's a thulium laser, fractional laser, which help help us create little tunnels into the scalp. And they've developed through one of my friends, actually, Dr. Amy Taub, who's a dermatologist I train with at Northwestern. Again, their own proprietary Carifactor products, all delivered through nanosome technology into the hair. And again, it's a pretty simple protocol that you do, but again, I think you can appreciate, again, when we do this, there's an increase in the diameter, there's an increase in the thickness of the hair. And again, something we do in our clinics on a pretty regular basis for our patients to improve the thickness and improve the hair counts. Again, it doesn't really matter skin type and skin color. We're able to get some really nice clinical results and clinical benefits when we use the Carolase procedure. And again, I think you also cover nutraceuticals in really
2 minutes to go.
Really good thing. And I want to just share with you, we have something called Nutrafol and we have something called Viviscal. This is Nutrafol. And what I like about it, it has about 15 clinical trials. Again, it's a synergistic activity of products of compounds put together. And again, the data shows really nice clinical hair growth, and Glynis Ablon here in the US has done a lot of these clinical studies showing how well this works in a group of patients. So I'm going to stop here because I'd rather get into the question and answer because I know we have lots of questions. And I just want to thank the Global Aesthetic Group for putting this together. It's been a wonderful learning opportunity for me and for, I'm sure, everybody that's on this call to hear these amazing experts and good friends do that. And again, I was Tapin, thank you. I was supposed to introduce you. I didn't see that on a text, but Tapin is like one of the gods of cosmetic surgery in our field. So he really doesn't need an introduction. Just one of the really forward-thinking, incredibly talented surgeons that we have. So thank you, Tapin. Thank you to Debraj and Tanush for having me, and to my co-chairs, Richada and Dan. It's just been a pleasure to be on this. So I'll be quiet now.
Fabulous. And I just can't imagine how much I've learned. The good thing is that all of this will be on YouTube by tomorrow. So if each one of us and the 350 people watching even now, it's 9:25 in India. So the 325 people who are live right now, if you want to go to the YouTube channel and listen to all of these talks again, you are more than welcome. We are right on time, 35 minutes left for the panel discussion. And I introduced Dan right at the beginning. And without any further ado, Dan's been given a special 4-minute slot because all the faculty thought they wanted to listen to his talk on exosomes. So over to you, Dan, and then we'll start off with the questions. And the questions are just keeping on coming in. So let's just get to the questions right away.
Okay, great. Well, first of all, thank you very much. I'm not going to waste any time, and then I'll talk about, can you all see this screen?
Not yet. If you could please share your screen.
Okay, hold on. Because I have this on.
What we can do, Dan, is Arunda has your talk as well. So Arunda, can you share the screen and Dan could talk through the slides? Would that work?
Sure. Yes, sir. Just a minute.
What for the sake of saving time, because I know there's very little time, the first thing I want to say is that as a surgeon that deals with nothing but hair loss and deals with nothing but taking care of patients that are dealing with hair loss, as Dr. Brusco is, it is very encouraging to see a group of dermatologists that are taking a profound interest into what we deal with every single day. And in the United States, it is not uncommon that we will be the last ones to see the patient, and they've been mismanaged, they've been misdirected, and they've been given therapies that have been thoroughly ineffective. And unfortunately, I hear and see the new therapies coming out, the peptides. Many of the dermatologists here in the US don't even know what a peptide is. I love to hear that they understand what a peptide is and how it can be used. We're going to talk for a few minutes about exosomes. I'm going to rifle through this, and I'm going to tell you that exosomes are basically signaling molecules. They are signaling molecules that are derived from mesenchymal stem cells. They can come from many different stem cell lines. Stem cells as in umbilical cord, placental, fetal urine, etc. However, not all of them behave the same. Not all of them respond the same. Not all of them are alike. Just like the PRP, there's a great variance. However, I can tell you undefinitively that I have found that I know what the proper exosome is, and I know the way that it is derived, and I know that it works. And I have shown in my clinic a 95% success rate. It is the exosome that I use from a specific company. I'm not going to name the company because that's not what's important. This is an exosome that is able to create a messaging signal to the tissue in its surrounding area when it's applied in the right concentration and in the right volume. Each of these 5 cc vials contain between 75 and 100 billion exosomes. An exosome is not a cell. It is a signaling molecule. It has no DNA, it has messenger RNA, and it has thousands of growth factors. We're going to rifle through just a few before and afters. This is a 70-year-old man that I injected 10 cc's into the top of his scalp. Unfortunately,
1 minute to go.
He'd been told by his dermatologist or his hair transplant surgeon in California that they could do 3,000 FUE grafts on him. I said, please, Don, don't do that. Come see me. I have something better. This is after only 2 months post-therapy. Next slide. You can check in her temporal region. We used only 2 cc's in each temporal area, and this is the regrowth after 1 month. The bottom line is the regrowth is, let's say, semi-permanent. It lasts beyond 1 year up to 2 years. It requires only 1 single injection and not multiple injections. And it literally is helping to rebuild and regenerate the hair follicle. Next slide. Especially effective in patients that have female pattern hair loss. This is a full scalp treatment with 10 cc's. That's close to 200 billion exosomes, and it is injected throughout the scalp, and that's the patient at 2 months. I know you're all thinking the same thing I am, which is exactly what I thought when I started using the product. How can this be? That's impossible.
And if you could please wind up in 30 seconds. I'm so sorry.
No problem. We don't see growth of hair in 2 months, but this is what we're seeing, and we'll show more later. Next slide. Again, female pattern hair loss, 2 months. Next slide. Next slide. This is actually me. That's my head. No, the one before. Back up. This is 10 cc's of the exosomal product in my scalp and the result after 2 months. This is a one-time injection. There'll be a lot more information to come. This is normally a lecture I give that lasts an hour to an hour and a half, and I apologize to try to just throw all of this together in one 5-minute slot. but I wanted you to be aware and know about the research that's being done with exosomes. It's in phase 3 FDA trials, and we will have this available both locally throughout the United States and internationally. And I'd be happy to create a second Zoom call where we can actually talk about it in detail. This is, as some of these other injectables are, in my opinion, the future of hair loss.
Thank you, Dan.
We are going to have what we need in the future of hair loss with injectables.
Thank you so much, Dan. We will certainly make it a 12-minute talk for our next hair talks as well. Thank you for taking us through a quick talk on exosomes. Over to Tapan and Amit to take the questions, and also the chairpersons. Please join in freely. If everyone could switch on their videos, please, and we could stop the sharing screen of the presentation, then everyone would be seen on one panel discussion. Request everyone to switch on their cameras. And over to Tapan and Amit, please.
Okay, so without wasting, I think we got a whole lot of questions coming in. So we'll take up these questions that we've got as of now. This is a question which I think, Asim, you can take in. It's from Dr. Munoz from Panama, and he says, what is the role of PRP, minoxidil, and QR678? Do they work in scarring alopecia? Maybe Rinki can also comment on it.
So I'll go first. So in secretarial alopecia, PRP helps in revascularizing the bed. We all know that it's a condition where, because of fibrosis, there is hypoperfusion. So that's somewhere where PRP definitely helps. But I do feel there are some studies where in conditions, autoimmune conditions like lichen planopilaris, where PRP has been shown to work. But I do feel we should stick to injectable steroids or oral steroids or some immunosuppressive agent there. And possibly for a burnt out case, to revascularize the bed and then perform a transplantation over that. I think that would be how I would use PRP. But I would love to hear what Dr. Rinki has to say.
What is your Rinki?
Yeah, right. So cicatricial alopecia, I think, will always be a combination therapy. And it will need immunosuppressants, immunomodulators, whatever is the traditional line of therapy. But early stages of cicatricial, see, we do not have studies yet with the QR678 on this. But as in individual patients that we have treated, early stages of cicatricial alopecia have shown good results in combination with the standard modalities of therapy.
Rinki, just a stupid query. What does QR678 stand for? What is QR?
Yeah, yeah, that's a good thing. I mean, I didn't mention that in my talk, but QR basically means quick response, so this was like, it's a code language that is used, so quick response to something that earlier had no answer. That was the idea behind naming it as the QR.
Okay.
Great. Okay, so the next question I think would probably be best put to Dr. Vivek Singhal, and that is, at what stage should we start treating genetic hair loss?
So genetic hair loss, as I mentioned in my talk, more than 50% hair loss has already happened when the patient is coming to you. So scalp visibility means 50% hairs are already gone. The density has already reduced and the numbers have already reduced. Photographic evaluation and trichoscopic evaluation will further document this. But the moment it is presented, it should be started immediately. There should be no further delay. Already you are late.
Great, thank you.
Okay, that's the next question is, this is from Dr. Urvashi Chandra from Delhi, and she asks, what would be the treatment plan once in a female pattern hair loss patient, once she develops resistance to minoxidil? Anybody who wants to answer. What do you do after there's resistance to minoxidil? What is the next step for it?
How old is the patient? I think a lot of it depends on factors that involve the age of the patient. If the patient is post-childbearing age, and you say they've developed a resistance to minoxidil, meaning I presume that they're no longer responding to the minoxidil, I would convert to oral minoxidil therapy in conjunction with finasteride orally, and it can be compounded as one pill. I've seen some of the protocols from some of my colleagues. Our protocol in the States is pretty standard. With a female patient, it would be 2.5 milligrams of finasteride combined with 2.5 milligrams of minoxidil, and of course, observation to ensure that there's no problem with any cardiovascular. But 2.5 milligrams is very low with minoxidil, considering that therapeutic doses are between 30 and 40 milligrams. I think that the fact that many physicians fail to take into consideration that many female patients can have a DHT sensitivity. It doesn't take much. The female pattern hair loss can have a DHT component. And we've seen many patients that come in that you would never think. And so it's always been a no-no to treat a patient with finasteride if she's female. Check out the patient's status in terms of birth and whether or not they're going to have any children. Are they post-menopausal? Where are they at? Of course, the basics of checking their iron in that secondary arena. I had a patient not too long ago from out of the country, and she asked her physician to check her iron level, and her physician said, that's ridiculous. There's nothing wrong with your iron. And she'd been having hair thinning, and she finally got the iron level checked, and it came back 8. And the physician said, no, that's fine. You're okay.
Okay.
Sorry.
Yeah. Sorry. Go ahead.
The point is that I think that there are a lot of different standards around the world in terms of how we treat and what we do. And I love these forums because we can share information about what are the next greatest leading things that, particularly for these female patients, because you know as well as I do, I've seen it. The female patient that comes into the office and, oh, I've got hair loss, and the dermatologist is like, oh boy, okay, because they don't.
Could we move to the next question?
Can you have Dr. When you have Dr. Rachita, I have a question, Dr. Rachita. Given a choice between oral minoxidil and spironolactone, what would you prefer?
Oral minoxidil and spironolactone?
Yeah, for a female pattern hair loss.
No, both are working at a different levels.
So
you can't compare oral minoxidil to spironolactone. However, spironolactone should be used in advanced grade of AGA, female pattern hair loss, because it has a role for female pattern hair loss. While oral minoxidil, why I'm in favor of oral minoxidil, if you have to read the study based on sulfur transferase enzyme, we have published 5 studies based on this enzyme, and we had shown that 40% of women have less expression of this enzyme. That means the conversion of minoxidil to its active metabolites is less when this enzyme is less expressed, and therefore the role of your oral minoxidil.
Okay.
Great. Thank you. Yes, I think the next question to Dr. Marco, please, and I'm just going to find it. I think the question itself is just a little bit vague, so please feel free to sort of, amend it to your knowledge. But it's recent advances in post-FUE or FUT care of hair after transplantation. So maybe some pearls that you can give on that, please.
Okay. Yeah. So I didn't mention a lot of the post-operative care. Probably I lacked that. I should have mentioned it. In the past, there's been some advancements on post-operative healing. Some people use PRP post-op. Sometimes people use PRP intraoperatively to speed up the healing. I have tried that. I find that it's a little bit effective. If you inject it intraoperatively, it can abbreviate the healing process. I have been using the last, again, no interest in this. I don't make any money of mentioning these things, but that's what I use, right? I've used a copper tripeptide solution for post-op for many years, and it tends to work really well, I think. It abbreviates the healing and decreases scabbing. Lately, I've been using a hypochlorous acid solution that is very effective as well. And I love the abbreviated healing that it has, the antibacterial properties. But even if you don't do anything, even if you just do Johnson's baby shampoo, and if you do a little bit of Vaseline or bacitracin or something like that along those lines in the donor zone of the transplant, either FUE or FUT, you're going to heal very well as long as your techniques were pristine during the execution of the surgery. So no need for anything special. The most critical time after hair transplant for damage to the follicles is the first 5 days or 7 days. So even if you do simple things, you're going to be fine. But there are products out there that speed up the healing. You can contact me directly if you want to, and I can give you some more details.
Okay, I would come back to something that's very interesting these days, and post-COVID hair fall, which we probably not covered too much. Just wanted to get people who are not speaking, Dr. Harsimran, Dr. Simal, could you comment on this, and even Sonam? Do you feel there is a definite entity post-COVID hair loss, or it is just the stress which is happening? And did you find that the 3 waves that we've had in India, the first, the second, and third, the hair fall have been kind of different in the 3 different waves?
Yes, Amit, I don't think it's been different. I think we know more about the last wave because this wave is still going on. But I have to say it's stress-related telogen effluvium like you'd get in any viral infection. So it's really been that. But because it was so intense, I think it really caused a lot of panic across everywhere. And
So
it was...
So did you find the hair fall in the second wave when we had the Delta variant? That time the hair fall was more, not in the first variant, which is a...
No, it was much more in the second wave. The second wave, yes, far more.
Harsimran,
far more.
Yeah.
Yes, it was much more in the second wave compared to the first. The impact of the third wave we are yet to see. I observed was that a lot of cases of female pattern were getting unmasked. Like we were seeing more and more patients going from chronic telogen to female pattern hair loss. So that kind of pattern was getting unmasked, and a classic finding was that ferritin was persistently low in these patients, maybe because of the with the Delta variant we had a spike in ferritin levels. So maybe the sudden drop was causing hair shock.
Sonam, what about you? Any specific input for people who are listening to us? Is there a specific thing that we're looking at when you treat post-COVID telogen effluvium, besides the usual stuff that we're doing?
Besides the usual stuff, I think what is very different in telogen effluvium with COVID setting in, like we all agree, the second phase obviously brought to us the more severe hair fall, where the clumps of hair that the patient would bring would be huge, much more than what we've ever seen in the past. So with this kind of hair fall, I think, like Dr. Harsimran also mentioned, nutritional support in the form of mesotherapy, support in the form of PRP, or other measures where we can help them to combat this faster would help us tackle the stress, would help us tackle the panic associated with it, and simultaneously improve the recovery. So I think nothing different that I have to do, but yes, timely management would be the key to getting over and tiding over it much faster.
But I have to say that also a lot, Amit, also a lot of the clinics were actually shut. They hadn't opened out, right? So when people were coming to, when they had all these concerns. So really, I think we did give them, sort of again, the heads up, the products for topical application and nutritional support till they came into clinic, which is when we started off with a lot of QR 6, 7, 8 back again. And I have to say that was very, very, very good for post-COVID hair loss. It just continues to really have great results.
Dr. Swain, the injectable component does have a significant anti-inflammatory effect with the PCR. Is that correct?
I'm sorry, I didn't get that. With the PCR?
The PCR, there's a significant anti-inflammatory effect with the injection of that.
You mean with the QR 6, 7, 8?
Yes, sure. Yes.
We didn't do it right after. I think obviously we did it right a few months after COVID, which is when people had the hair fall. It wasn't immediately after. It was typically after about 3 to 4 months. It was fine. We didn't really see any sort of side effects or anything with that.
Yeah, I just want to make one comment. I want to make one comment.
Yeah,
we haven't seen as much with the Omicron with hair loss yet. You will. You will. You'll see more probably than Delta. And I think the biggest thing that we're doing in our clinics with all these patients, besides everything you're mentioning, except QR because we don't have it here, is you have to spend time assuring these people that you can take care of them, and it's going to grow back with therapy. And just the talking to them and reassuring them is as important as everything else we're doing. Because they're totally, I mean, for lack of a better word, they freak out because they
freak out. Yes.
Yeah. And we can give them so much comfort just by telling them, hey, this has been reported. This is part of COVID. And yes, there are things we can do. Everything you learned today can be done. So just know more hair loss is coming, and it's going to be a lot more.
Yes.
I just had a comment to make, actually. A lot of us tend to believe that hair fall is not that important. And especially in countries like India, we have the goods and services tax, which is levied on people with hair fall, which means that technically they're considered consumers and not really considered as patients. But really, I mean, all the trials that we are conducting at the aesthetic clinics, it seems to suggest greatly what is not on the head actually starts impacting what's inside the head. So from that perspective, once you lose confidence, once you start losing hair, especially for women, I mean, it's important for all of us to put this together and sort of run advocacy campaigns with our respective governments who tend to believe that hair is something very frivolous, because as the quality of life increases, I mean, you know, and women start losing clumps of hair, it's really not funny for many of them. So it's something that's very, very important for all of us to address.
I mean, honestly, I think that most of the consultations during the pandemic that people reached out to were for hair loss. That is for sure. I think 80% of them.
Agreed. Fine.
And you know, Dr. Debresh, I've gotten pushback on this, but I personally have taken upon myself to redefine the nature of androgenetic alopecia, because I think it has been taken way too lightly. And if you look at it very carefully and you break it down, there's no question that it fits all the criteria of a genetically inherited chronic pathological disease. It is a genetically inherited chronic pathological disease. Now, you don't die, but a part of your body dies. Now, your hair may not be considered essential, but your hair follicle slowly degrades, just like you would if you were a chronic diabetic. You're genetically disposed, and not everybody is.
Just in the interest of staying on agenda, because we have so many unanswered questions. Sorry, Dr. McGrath, I'm just going to butt in there. I predicted there would be a lot of questions on QR 678, and I wasn't wrong. So Dr. Rinke, over to you again. I'll just give you 2 or 3, and you can just give us maybe a short answer on a few of those. So it's, what is the frequency of sessions of QR 678? Are there any maintenance sessions? Are there any treatments given in between? And can it be mixed with PRP? And my question is, even, does it need to be? So over to you, Dr. Rinke.
Yeah, so the frequency of sessions has been found, the most effective has been found to be once in 3 to 4 weeks. That is the ideal frequency and the time interval between the sessions. As regards combination with other modalities of therapy, so we all know that hair loss is a multifactorial disease. And as scientific people and as doctors, we do understand that hair loss in general would generally need combination of therapies. Now, the QR on its own is, just on its own, can be used for very early stages of androgenetic alopecia, as in up to grade 2, grade 3 male pattern, and probably the early stages of female pattern. However, as you go higher on the scale, it will need, and it will probably give much better results, as the study that has been published and that I had shown in my presentation, when you combine it with other modalities of therapy which target other areas of androgenetic alopecia. And however, if you have conditions like the post-COVID hair loss and acute telogen effluvium, which I had mentioned in my slides, you have conditions like post-chemotherapy hair loss. In such cases where there is no hormonal element to the disease, the QR678 alone has been found to be very efficacious. In fact, the studies that have been published are with the QR678 therapy alone. And the last but not the least, combination with PRP, I think I've been very clear in my presentation as to what are the pitfalls of the PRP and how the QR circumvents. So that's exactly the reason why the QR came into being, to tackle all the uncertainties and unpredictabilities with the PRP. And according to me and according to the studies that we have published, there is actually no necessity of combining the PRP with the QR678. In fact, the couple of doctors here who have used it, I think Dr. Simil also mentioned that they've practically phased out PRP once the QR678 has come in. See, basically it's like this, you know, if you have orange, right, which has vitamin C. Now we all know orange has vitamin C. You have oranges from India, you have oranges from the European Union and so on and so forth, but every orange has different concentration of vitamin C. So is it that you're going to just squeeze the orange and put the vitamin C onto the face? Or do you think that you're better off putting a serum which is manufactured in standardized conditions and which delivers a certain concentration, 15% or 20% as mentioned on the label, and you know that that's the concentration of vitamin C in the bottle of serum? So is it something that you're going to get, are you going to get vitamin C right from the orange? That's what is going to make the difference to your skin? Or are you better off taking something which is standardized and where you know the concentration of vitamin C? So that's basically the difference between the QR and the other solutions which offer growth factors as the answer to hair loss. So that's what
Tappan, can I just say something real quick? So just so everybody knows, and Debraj and I have spent hours talking about this, it is not yet available QR in the US. Because, and correct me, Debraj, if I'm wrong, but it would be considered a drug. It'll cost about $10 million to go through the FDA process. And unless he's going to write that check or whoever is funding this, but we're happy to do those studies as soon as you have those funds. I think between Marco and Dan and I, we're happy to lead those trials and get things running. But we have, if you've noticed from the Journal of Cosmetic Dermatology, we try to publish every one of these that we can publish and get through peer reviewed, because it's real. There is no question after reading what I've read over the last how many years now that it works and it's good. And the team has done an amazing job in what they've done. So I just wanted to give them some compliments on that.
Thank you, Dr. Gold. 5 minutes to go.
Is it considered a drug or is it a human biologic? Do you know?
Yeah, it's a cosmetic in different parts of the world. So in Kuwait, it's registered as a cosmetic. In the European Union and the UK, it's registered as a cosmetic. These are all biomimetic peptides which are derived from plant sources. So they are considered as cosmetics. But the problem is at this moment in time that for administration, we find that it works well with either the derma roller or the mesotherapy. Now, in different parts of the world, the usage of the mesotherapy or the derma roller can be considered a class 1 medical device, leading it therefore to be considered a medical device rather than as a cosmetic. However, the next rounds of patents are being filed right now. So in about a year and a half or so, we should have a completely topical solution which reaches the hair follicles just as any other topical cosmeceutical would. And at that point, it will be the right time to enter North America. Michael also lives in a country which is very, easy with litigation. And I don't think the team, startup is capable of taking the US on at this moment. And that's why we would prefer to stick to Europe and the UK. We've got 4 minutes left.
It's a drug. Yeah. It's a drug right now.
We've got 4 minutes left. And what we'll do is we'll try and bring everyone in on the conversation who've not said anything. So Dr. Bhavesh Gupta, who's a hair transplant surgeon. Bhavesh, do you want to say anything? Do you want to make any comments, etc., before we move on to the rest? You're muted, Bhavesh.
Yeah, I would like to use it as soon as possible, sir, and I'll definitely give my feedback on this.
No, not about the QR, about hair talks and about your presentation and about hair transplant in general. Would you like to speak about anything? You do a wonderful job. Do you want to comment on anything or ask any of the speakers anything?
I have as of nothing specific, sir.
Okay, Dr. Arundha, over to you.
I just had a question for Dr. Harsimran. So about hair Botox you had mentioned, that is something that we didn't elaborate on. Could you please?
Yes, so what it basically does is it just relaxes the muscles of the scalp and improves the circulation to the scalp. That is the mechanism how it acts. But as I said in my talk, that it needs a very high dosage. That is about approximately 10 sites are injected per session with 30 units each. So that's a lot, and evident results are seen only after about 4 sessions as per studies.
That's too close to
that
the fatal
cannot
dose
be
as
the-
well. Huh?
Yes, so that cannot be picked up as a treatment of choice. Like it is still under research. Like
Debraj, I think we should take last couple of questions and then wind up.
Yeah, so just Dr. Monica's not said anything. So Monica, do you want to say something as one of the younger coordinators?
No questions from my side, sir.
All right, so over to the moderators. We have 2 minutes before we say goodbye to each other. And Tapan, do you want to speak about you? You are such an amazing name, fame. You've got everything in injectables. Why are you moving into hair? Why is hair so important? And I also saw some of your reels yesterday talking about other devices which you've been using recently. I'm a follower of yours on Instagram, as are probably a lot of the faculty here. So what's taking you from injectables and being the spokesperson for all these injectables to all these other devices and hair, especially in your practice?
You know, that's a great question. And I think if I just step back, I was on stage with the great Arthur Swift a few weeks ago, and we were just reminiscing, and we said, you know, certainly in the UK, we can think of aesthetic medicine as being a field that really didn't exist before 2000. You know, it was only after the advent of Botox and things that this whole field of aesthetic medicine, of course, we had plastic surgery then, but aesthetic medicine has only been there. So I like to think that for some of us, we've been there from inception or conception. So, you know, we've been there from the embryonic stage. Now I look at it that something that started very, very small is now becoming such a rapid and accepted field. And the great thing about it, Debraj, is that there's many aspects of other streams of medicine that fit into it very well. So if you take aesthetic medicine as conventionally being injectables and skincare and device delivered treatments, there's other things like longevity medicine, lifestyle medicine, weight loss, hair, vaginal rejuvenation. So there's many things that now actually fit into that. And what I think we're going to find over time is that these are not distinct spheres, but it's just a lot of interconnected circles. And it allows physicians who have a certain interest to actually pick and choose those things in aesthetic medicine that they want to follow. So certainly for me, as all the panelists have been saying, there are lots of people presenting. Up to now, I don't really feel we had lots of, you know, definitive options. I'll give you just one last point. Only 10 years ago in England, hair loss was not really even treated by dermatologists, maybe one or two. It was treated by trichologists who, other than very few names, you know, one or two good ones, they were not really able to offer much solutions. So there was a lot of disparate people, very desperate. I love what you said about what's not on the head affects the head. So there was a lot of distraught people, but they really didn't have anywhere to turn. And I think the more evidence-based, the more solutions that actually have a definitive outcome, better for everyone. So I'm definitely, you know, entering it as a, you know, a real novice. But I think what you've organized today is magnificent. And I thank you very much for allowing me to moderate the session. Thank you.
Thank you, Tapan. My last question would be for Amit, because he's been asking all the questions and he's not had the chance to really talk about stuff. I have known Amit as a friend for the past possibly decade and a half, and he's been at the forefront of teaching so many dermatologists and so many cosmetologists all over India and globally. Amit, what changes are you seeing? I mean, what's changing? I mean, I know dermatologists have been getting into dermatosurgery, and there's so many changes coming up. But where do you see aesthetic medicine, maybe based on what Tapan said, 10 years from now? You've had the chance to see the past 10 years. When you look at the rear view, what's the future 10 years bringing in?
I think it would become probably as part of the core dermatology as we've had other things in the past, in the sense that aesthetic dermatology would become a part of your proper dermatology. And as more and more medical colleges, more and more institutes are now kind of keeping that as part of their courses. So aesthetic dermatology would not be that kind of a panacea that everybody opts for. It would more would be a routine thing that you learn. And we are evolving with time. Unfortunately, we've got stuck with certain only injectables. We need to kind of graduate to something new every now and then. And that's why probably hair comes in. Hair gives you the liberty to kind of experiment with things, gives you the liberty to kind of get into newer procedures as well. And it's been a wonderful learning experience, I must say. The best, probably the webinar that I've attended after a long time.
Thank you so much, Amit. Over to the chairpersons now for the final remarks. Dr. Gold, Dr. Dhurat, Dr. Magrath. Before we close this, we are 3 minutes over at this moment, so a couple of minutes to each one of you.
It's been great. I'm just going to say thank you for doing it. Thank you for putting it on. Arunda, thank you for all the communications, because you kept all of us in the game, and it's just been a pleasure to be part of.
Yeah, same here. The conclusion of this wonderful CME is that it's well organized, and all topics from the basics to advanced cases or hair talks were taken by stalwarts across the globe. It's not only the Indian stalwarts, but across the globe. The well organized CME, congratulations to organizers.
Thank you. And I can't tell you how profoundly pleased I am to be in an arena with esteemed dermatologists that are really taking hair seriously, because there is so much to know and so much to understand and so much to learn how to do in order to help these patients. And these patients are desperate. They are desperate. And it warms my heart, as I'm sure it does Marcos, to see that there are a panel of minds like this that are very serious about curing this process and getting this process under better control. It warms my heart. And thank you all for taking the time to be here.
Thank you, everyone.
Just thank you to
Debraj
and Tanuj, for putting all this on too. So this has been great.
Thank you. Without you, all of this would not have been possible. Different parts of the world, and it's still 275 people watching at 10:05 Indian time. So thank you, everyone. Stay safe, and until we meet again, hasta la vista.
Thank you.
Thank you. Good night.
All right, bye-bye. Thanks.
Good night.